Hello and good morning. I am Dr. Jhalak Shah. I am Secretary of Academy of Pediatrics, Rajkot branch. A very warm welcome to one and all on this fine morning. On behalf of Infectious Disease Chapter IAP and Academy of Pediatrics, Rajkot, to the 7th ID Connect CME. This will be both physical as well as virtual. Monsoon reminds us of many infections. So today we are here to discuss, to learn, to meet and greet in this monsoon season about the infections. Without much delay, I would like to invite our President of Academy of Pediatrics, Rajkot, to say a few words on the occasion.
Hello, good morning and welcome everyone on 7th ID Connect CME, organized by ID chapter of Indian Academy of Pediatrics and Association of Pediatrics Rajkot. I welcome Dr. Yagnesh Popat sir, chairperson of the ID chapter. I welcome Dr. Yogesh Parikh, president AOP Gujarat state. Presence of all of you only make this event successful. I welcome each and every faculty travel along to be here to educate us. Dr. Digan Sastri sir, Dr. Raju Shah sir, Dr. Shamir Shah, Dr. Kirit Sishodia sir, and Dr. Chetan Trivedi. They are not here still. I welcome our own faculty, Dr. Palak Hapani, Dr. Jai Dhirwani, Dr. Mehul Mitra sir, Dr. Jayesh Onwani. Not taking much of your time, please enjoy and experience this CME and please enjoy our hospitality and food. Thank you.
May I now take this opportunity to invite Dr. Yagnesh Popat, Chairperson, Infectious Disease Chapter IAP. Thank you, sir, for giving Academy of Pediatrics Rajkot this opportunity to conduct the CME. Sir will give insights into today's program.
Hello friends. Respected past chairperson of the ID chapter, Dr. Digan Sastri, Dr. Raju Shah, AOP Rajkot President, Dr. Jhankhna Shanghvi, Secretary, Dr. Jhalak Upadhyay, AOP Gujarat President, Dr. Yogesh Parikh, our senior AOP Rajkot members, Dr. Dhananjay Shah, and other colleagues from Rajkot who are attending this CME physically, and my dear old friends across India who are attending this CME virtually. Good morning and welcome to you all. Friend, today I am here with the 7th ID Connect CME in front of you. This is a unique program for me because of number of reasons. Number one, it is being hosted by my home branch, AOP Rajkot, and that too, AOP Rajkot has two beautiful ladies at the helm of affairs. So that is a speciality of AOP Rajkot. Secondly, this is for the first time is an hybrid event where it is physical event for the Rajkot and the surrounding IAPians while it is virtual event across India. This event will be broadcasted across India for your view. Friends, Corona is receding. We have almost zero cases in Rajkot and surrounding areas. But then this is the time of resurfacing of other organisms like malaria, dengue, viral ARI and others. So friends, let us learn from the faculties, ID specialists across Gujarat who have traveled to Rajkot and they are present here physically. Let us learn, relearn and de-learn from them the art of pediatric practice. Dr. Khea Uttam Ghosh, our secretary, Dr. Abhay Shah, our academic affair administrators are not here with us today because of some social issues, but I acknowledge their contribution in organization of their CMEs. Friends, wish you all a happy learning. Thank you.
May we now please proceed with the lamp lighting. May I invite all the dignitaries on the stage. Sir, Dhananjay sir, Parikh sir, Digan sir, Kirit sir.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे.
Thank you. May I now please invite Dr. Digant Shastri. Sir has been past president of Infectious Disease Chapter, IAP. Sir, please.
Good morning, everyone. My dear friend and chairperson of Infectious Disease Chapter, Dr. Yagnesh Popat. My another friend and president of Academy of Pediatrics, Gujarat, Dr. Yogesh Parikh. Team AOP Rajkot led by Janknaben and Jhalak, as well as all dignitaries, all invited speakers, delegate friends, and attendees on the virtual platform. As said by Dr. Yagnesh, that luckily the COVID-19 pandemic is, as of now, appears to be in the declining phase, and that has made our physical conferences also possible, where we can meet and greet and interact with our fellow IAPians, our friends and our colleagues, and also we can update our knowledge. And in that context, the project ID Connect, started by Yagnesh, Dr. Khea and Dr. Abhaisha, is very much useful in connecting the people, connecting the delegates, collecting the IAP members with the stalwarts of infectious diseases. This is 7th program in the row, and as Yagnesh said, it is special program. For me also it is a special program, because coming to Rajkot, participating in the events organized by Rajkot is always a pleasure for me. And this is a pandemic, post-pandemic, or you can say that before COVID and after COVID. So after COVID, this first ID event where I am participating. So I wish all of you a happy learning. I also congratulate the ID chapter. I also congratulate the AOP Gujarat and AOP Rajkot, the host branch, and wish you all happy learning. Thank you.
Thank you, sir. May I now please invite Dr. Dhananjay Shah, sir, to say a few words on the occasion. Sir is a senior pediatrician from Rajkot.
First of all, I welcome all the dignitaries, attendees, and the viewers of this online CME. You will be informed that Rajkot IAP was baptized in 1989, sorry, and it has completed 32 years of its glorious journey. And the 7th ID Connect CME is a landmark in the history of academic activities at AOP Rajkot. And I wish that all of our members will become members of the ID chapter, and in the presence of Dr. Yagnesh Popat as the chairman of ID chapter, I am sure many more activities will happen. Thank you so much.
And now I would like to invite Dr. Yogesh Parikh, President, Academy of Pediatrics, Gujarat, to say a few words on the occasion. Please.
Warm welcome to Dr. Raju Shah, sir, Dr. Chetan Trivedi and Dr. Yagnesh Bhai. First of all, this is a proud moments for the Rajkot, AOP Rajkot and AOP Gujarat to host the 7th ID Connect CME of the ID chapter, and it is more proudful to Yagnesh Bhai Popat is a national chairperson of the ID chapter. So, and our all stalwarts of the ID Connect, Dr. Digan Bhai, Dr. Raju Shah sir, Chetan Bhai, and Dr. Swati Ben, Dr. Palak, and Dr. Jankhna Madam and Jhalak Shah, both young ladies doing excellent job during the pandemic, after the pandemic, and before the pandemic. So both the years are grateful for the AOP Rajkot, and warm welcome on behalf of our AOP Gujarat Secretary, Dr. Manish Bhai. He conveyed message because he is busy with the e-Gurukul program. So thank you very much for inviting us and making host of these events. Thank you very much.
Thank you, sir. May I take this opportunity to invite Dr. Raju Shah, sir, who has been past president of Infectious Disease Chapter. It's an honor to have you, sir. Please. Sir, please say a few words on the occasion before we begin with scientific session.
Good morning, friends. Dr. Yagnesh, Dr. Yogesh, and friends. It's indeed a great pleasure to be here at Rajkot for the first such physical presence CME for me. It's after a long time meeting all friends is always a pleasure. 7th program in the line of ID Connect is a very important program in a way that first time there will be a physical as well as the digital CME will be conducted, and sort of an experience that will get us some more knowledge that how do we manage such type of CMEs. The programs that were arranged in the past ID Connect were really of very great help to all the practicing pediatricians, and I am sure today's program also, with the topics that we are going to cover, will enhance the knowledge of practicing pediatricians, and that will definitely help in a long way. My congratulations to the Rajkot IAP and Gujarat IAP for organizing this, and wish all the best to the program. Thank you, friends.
Thank you, sir. We now begin with our scientific session. I would like to invite Dr. Digan Shastri, sir, to take the first session on approach to child with soft tissue infection. Sir is a senior pediatrician at Kilol Children Hospital, Surat. He has been president in at national level, Indian Academy of Pediatrics in 2019, member standing committee, International Pediatric Association 2019 to 21, chairperson, International Pediatric Association, chairman, IAP Infectious Disease Chapter 2013. Sir has many publications, including many articles and textbook. He has also been editor of various textbook. Welcome, sir.
So, good morning, friends, and at the outset, once again, sincere thanks to the organizers, Rajkot branch of IAP as well as ID chapter, for giving this opportunity, and The topic which today I am going to discuss is the skin and soft tissue infections in children. The presentation time is 20 minutes, so I will be mainly focusing on the common bacterial infections in children. If time permits, I will be touching upon the fungal infections and the parasitic infections, and I will be taking you through some case scenarios which we all encounter in our clinical practice. So we all know that the healthy skin acts as a mechanical barrier against entry of any sort of organisms. When there is a break in the epidermis, it facilitates the entry of organism, and which can lead to skin infections. If the person is immunocompromised individual, either because of primary immunodeficiency, secondary immunodeficiency, or because of some medication, this puts the person at higher risk of getting skin infections. Similarly, conditions which leads to the lymphatic stasis, that also puts the person at a higher risk of getting the skin infection. Though in children the peripheral vascular diseases are less common, but if such condition is there, that again leads to it puts the child at the risk of skin infections. The skin infections can be, and the most common route is by direct invasion. Also, it can be by toxin mediated infections, like you have a staphylococcal scalded skin syndrome, which is toxin mediated condition. And at times it is because of the systemic infection, which is because of hematogenous spread of the infection. The infections can be divided into the two categories, the superficial infections and deep infections. Please remember, the deep infections are having more serious outcome and more serious progress, and we have to be more vigilant and more aggressive in managing this condition, while the superficial skin infections by and large are easy to treat. Now, before we move on to the skin infections, I think it will be most relevant to just revise the anatomy of the skin. And if we know the different parts which we learned during the first year of MBBS, and which part of the skin is involved, based on that the pathology will differ. So you have the epidermis as well as dermis. Below the dermis you have the subcutaneous fat, then you have the fascia, and then you have the muscle. The hair follicles are originating from the dermis. Now, why this is important to learn? Because depending on the part which is involved, the condition will be labeled accordingly. So if there is a infection which is limited to the epidermis, it is called as a impetigo, and it is in the outermost layer of the skin. If it is infection which is extended to the dermis also, and superficial dermis, and involving the lymphatics, it is erysipelas. If there is a single hair follicle which is involved, then it is labeled as folliculitis. If there are multiple hair follicles, then it is labeled as carbuncle. If the infection spreads little down into the subcutaneous level, then it is called as a cellulitis. If the infection gets still further down and involves the fascia and the muscle, it is labeled as a necrotizing fasciitis. So in short, based on the parts of the skin, the layer of the skin where the infection has happened, the condition will be labeled as from impetigo to the necrotizing fasciitis. So with this background, let us go through some cases. First two cases. First case is a 20 months old boy, rash on the face and if you see there is a crusty lesion, honey colored crusty lesion which are around the face, on the face, around the mouth and nose. Another case, an infant who has a bullous pustular lesion on the lateral side of the thigh. So, looking to these two pictures, what is the condition? It is a impetigo. The diagnosis is impetigo. The difference is, here it is the first case is a pustular impetigo, while the second case is a bullous impetigo. So, we all know the impetigo is a highly contagious disease caused by gram-positive bacteria. The two common organisms are Staphylococcus aureus and group A beta hemolytic streptococcus. And as I said, there are two variants, the bullous impetigo and non-bullous impetigo. And if you see how to differentiate between the impetigo contagiosa and bullous impetigo, then for the impetigo contagiosa, the causative organism is Streptococcus pyogenes is a more common and Staph aureus, while the bullous impetigo more commonly by the Staph aureus. The distribution area again differentiate. The bullous impetigo is mainly on the abdomen as well as the flexor areas, while the impetigo contagiosa is more on the face, as we saw in the picture. The appearance also differs. The impetigo contagiosa, it is vesicles or pustules, dark gold crusted lesion or honey color lesion, while the bullous impetigo, it will be a bullous filled with the fluid or flaccid bullae may be there, while the systemic symptoms will be absent in the impetigo contagiosa, but it may be present in the bullous impetigo. So, by the clinical presentation, distribution, appearance of the lesion, you can definitely differentiate between the bullous and non-bullous impetigo. For the diagnosis, we all know it is a clinical diagnosis, no specific investigation is needed, no specific laboratory tests are needed, even ASO titer is also not needed, and at times we think of going for the culture, but by and large the cultures are not needed. You need to do the culture, blood culture, as well as to know for the carrier state, you will go for the culture from the nares. So, when to go for the blood culture? You will go for the blood culture when you are suspecting MRSA infection, or where there is a outbreak of impetigo, or where there is a presence of post-streptococcal glomerulonephritis. And for detecting the carrier state, you will go for culture from the nares. So, how to treat it? The first and most important is a topical treatment. It usually does not need any systemic antibiotic therapy unless until the patient is having systemic signs of toxicity. So, you either use mupirocin or you can use fusidic acid. Please remember that the frequency of application, mupirocin you have to apply 2 times a day for 7 to 10 days, while fusidic acid you have to apply 5 times a day. So, from the angle of convenience, the fusidic acid 2% is a better molecule, otherwise both of them are having equal effectiveness. Systemic antibiotics are indicated only where there is a widespread impetigo or where there is a perioral or deep involvement is there. In that case, you will go for the systemic antibiotic therapy. Please remember that treating the impetigo will not prevent post-streptococcal glomerulonephritis. So, this complication cannot be prevented by using the antibiotics. We move on to the another condition, case 3 and 4. A 4-year-old boy with soft swelling and pain which is for last 2 to 3 days. And if you see, there is a erythema, induration also is visible, and there is a pointing. What is it? It is a furuncle. So, it is only one hair follicle. Now, you have another case, a child who is having swelling, 2-year-old child, redness and pain in the breast since last 2 days. The area is warm, tender, fluctuate swelling with discharge. So, the diagnosis here is a abscess, breast abscess, right. So, for furuncle or breast abscess or carbuncle, the main treatment is moist heat and incision and drainage. These two are the main line of treatment. In this case, the pediatrician started with cefixime and clavulanic acid. Is this a right antibiotic choice? No, because here the antibiotic should be based on the probable causative organisms, and you need to cover the Staph aureus or Streptococcus pyogenes, and the cefixime will not cover that organism. So, this was not the right correct antibiotic therapy. So, what is to be started? So, you have two options. If the patient is clinically stable, in that case you can start with the oral antibiotic in form of cephalosporins or a cloxacillin or oral coamoxiclav. While if the patient is having systemic signs and toxicity is there, in that case you can start with parenteral cefazolin or a parenteral coamoxiclav. For prevention of recurrent pyoderma recurrence is very common, and many times patient comes and tells, sir, you treated it and why it has happened again. So, we have to educate the patient about how to prevent it further. So, first and most important is good personal hygiene, hand washing, trimming of the nails, improve environmental condition. If there is a lot of overcrowding in the family, then overcrowding is to be avoided. Avoid sharing garments, towels. Apply the antibiotic creams like mupirocin on the traumatized skin. Evaluate the contacts. Many times there is a contact in the family who is having pyoderma, and then it is transmitted. So, evaluate the contact for pyoderma as well as the carrier state, and treat underlying conditions. If patient is having atopic dermatitis and patient is having scratchings because of itching, this facilitates the entry of the organism and it will lead to the impetigo. Also, for prevention of the infection in the case of recurrent impetigo, you can advise application of mupirocin inside the nares, axilla, perianal area 3 times a day for 5 days every month. This will also prevent. But please remember, there is no role of systemic antibiotic therapy, preventive therapy, except for the clindamycin. Now we move on to the case 5. 7-year-old child, she had the chicken pox 5 days since last 5 days. No bath was given as a traditional in the many of the families, and now patient has come with painful blisters and redness on the back and posterior part of the thigh. So, if you see, there are lesions, several lesions, the chicken pox rash which has got infected. So, what is it? It is a case of cellulitis, post chicken pox cellulitis. So, how should we treat it? So, first and most important is to send the culture, that is from the local site as well as from the blood culture. Because this condition, as I said, more deeper the infection, it will be having a more poor outcome as well as more risk. So, in that case you have to be little aggressive and you will start with the parenteral antibiotic. So, injection ceftriaxone and cloxacillin, which will cover both the Streptococcus pyogenes as well as Staph aureus. And in this case, the patient continued to running spikes of fever, and the repeat counts were done, which was showing 28,000. So, here you have started with the appropriate antibiotic, not like in the previous case where you had started with cefixime and clavulanic, but you have started with the appropriate antibiotic, but still patient is running fever and also the counts are high. So, what could be the reason? So, reasons could be either there is a septic focus somewhere else in the body, or like a necrotizing soft tissue infection, or it could be because of the resistant organism. Because now we are getting even community acquired MRSA is also more frequently we are getting such cases. So, this thing also we have to keep it in mind. So, another case having redness, induration, tenderness and febrile patient. So, it was a case of necrotizing fasciitis, where you have a characterizing local tissue findings where there is a redness, tenderness, wood-like feeling when you touch the skin, and there is a systemic toxicity. Patient has got fever, leukocytosis is there, delirium is there, septic shock is there, or renal failure is there. And if you investigate, patient will have a WBC count more than 15,000. There will be electrolyte imbalance in form of hyponatremia, and the blood sugar level was also high in this case. So, how to differentiate between cellulitis and necrotizing fasciitis? So, the difference between these two conditions is that the vital signs will be more unstable, as well as the general condition of the patient will be not that good compared to cellulitis. The necrotizing fasciitis, the general conditions, toxicity will be there, and the vital signs instability may be there. So, it is a infection of tissue involving the skin and underlying muscles. And to differentiate it from the cellulitis, as I said, when you touch the skin, it will be wooden hard feel. There will be constant pain, severe pain. There may be cutaneous anesthesia. The skin necrosis may be there. If you feel, you can feel the gas also, or if you go for the X-ray, you will have a gas on the X-ray also. And the edema will be beyond the margin of erythema. So, in case of cellulitis, the edema is just up to the margin of erythema.
4 more minutes, sir.
Yeah, it will be, I will be completing. So, as I said, more severe progress and more generalized hemodynamic instability with more toxicity is seen in the case of necrotizing fasciitis. There are two varieties. One is monomicrobial necrotizing fasciitis, which is more common, while less commonly it is polymicrobial. And microbial fasciitis, the common pathogens are Streptococcus pyogenes, Staph aureus, anaerobic organisms, while polymicrobials can have all Enterococcus as well as E. coli and other organisms. For the treatment, again, we will have a surgical debridement is the prime most important thing. If you don't do this, then the patient will continue having toxicity as well as hemodynamic instability. So, it should be there. Gram stain of the exudate and culture should give us the clue about the pathogen, and based on this you can modify your antibiotic therapy, while empirically you can start with ceftriaxone plus clindamycin or vancomycin depending on the setting or depending on the severity of the condition. As I said, now MRSA, we are getting community acquired MRSA also. If MRSA is suspected, you can go for vancomycin. If it is MSSA, you can go for cloxacillin or cefazolin. Last case in the series, I think second last case, 6-month-old child, multiple bullous lesion for last 24 hours, and the diagnosis is very clear. It is staphylococcal scalded skin syndrome, which is caused by the exotoxin produced by the staphylococcus, and usually it presents like a erythematous tender skin lesion which progress to desquamation in 24 to 48 hours. More common in younger children less than 2 years age, but even most of the cases are seen in the young children who are less than 5 years age. If you go for culture, invariably it will be negative, because this is caused by the exotoxin. Usually the child is febrile and very fast progress to the shock, and the treatment is first general cephalosporin or cloxacillin unless you are suspecting MRSA. Last case in the series, 10 months old female who has come with a high grade fever and neck swelling since last 4 days, weight is 8 kilogram. So, the child is not good, means no growth failure, there is no past history of recurrent illnesses. This is a first illness, and high grade fever and neck swelling. The swelling is tender, warm, fluctuant, and no other positive clinical findings. So, if you can appreciate in the picture, the child is having a abscess in the neck, right? And so, the abscess was drained and culture was sent, which grew beta-lactamase producing staphylococci, which were sensitive to vanco, clinda, linezolid, trimethoprim sulfamethoxazole, and resistance to oxacillin, erythromycin, penicillin and ampicillin. So now you have a staph which is grown, which is resistant to oxacillin, erythromycin and penicillin. So out of these 4, what is the type of staphylococcal? It is clear that it is a community acquired methicillin resistant Staph aureus infection. It's just a comparison between hospital acquired MRSA and community acquired MRSA. Usually in community acquired MRSA there will not be any history of contact to the healthcare facilities. The community acquired MRSA is more common in the young children compared to while the hospital acquired MRSA is more common in older children. Skin and soft tissue infections again more common with in a community acquired MRSA, and resistance this antibiotic resistance is found with many agents in the hospital acquired MRSA. Just we will take you through some list of fungal infections. As we see, the 8-year-old child annular erythemus scaly plaque with central clearing lesion. It's a case of Tinea corporis. And please remember, diagnosis is mainly clinical. You can go for KOH preparation where you will find filamentous hyphae, and treatment is topical clotrimazole or miconazole, ketoconazole, and please remember the duration of the therapy. Similarly, a child who has come with patchy alopecia, scaling and itching and black dot appearance. So it is a case of Tinea corporis. This thing. So the treatment here is we have to start with the oral griseofulvide, or you can start with the itraconazole, and also you have to use topical antifungal and ketoconazole. Pityriasis versicolor, very common condition, or Tinea versicolor. Again, there is a patient present with hypopigmented patch on the upper chest, neck, arms. Usually these are self-limiting conditions, but naturally it attracts more attention by the parents and more concern by the parents. So usually topical therapy along with the systemic therapy you will offer in case of recurrent. Lastly, should I complete?
Few more seconds, sir.
Yeah, okay. So then let me just take you to the last slide about the key messages about the skin infections. So bacterial skin infections are common in children, as we all know, and we are the first treating physicians for it. So we should know it. The 2 common organisms are Streptococcus pyogenes and Staph aureus. Topical therapy, local mupirocin or local fusidic acid are the mainstay of the therapy, while oral therapy you can have a cephalexin or cefadroxil. For parenteral therapy you can use cefazolin, coamoxiclav, clindamycin or ceftriaxone with cloxacillin depending on the type of organism you are suspecting. For resistance to macrolide is on the rise. Similarly, higher agents like vancomycin should not be used indiscriminately. It should be kept reserved, and community acquired MRSA should be kept in mind while we are dealing severe infections or the infections which are not responding to the treatment. Thank you very much.
Thank you, sir. We appreciate your time and efforts. It's a pleasure to have you here at Rajkot. May I please invite Dr. Yagnesh Trivedi sir to present a memento to Dr. Digant Shastri as a token of love and appreciation on behalf of AOP Rajkot. For the next session, I invite Dr. Chetan Lal Seta for a session on fever with rash in children. Dr. Chetan Lal Seta is a senior cosmetologist and dermatologist at Rajkot. Sir has held various positions like Sir was a past secretary of IMA Rajkot, past president recently of IMA Rajkot. He was also, he has been organizing secretary for various Cuticon, then Dermacon. Then Sir has also been President of President of Dermatology Society of Rajkot since 2012 and still continued. Thank you. Over to you, sir.
Very good morning to all the seniors of Pediatric Associations and my colleagues of Pediatric Association. At the outset, I would like to thank AOP Rajkot and ID Connect chapter for inviting me for this talk. And when I went through the schedule of topics, I thought I am the only odd one out. It's a full continental dish and I am just a Kathiawadi menu in that. But anyway, I will like to add some spice to it. As in today's era, we are dealing with interfaculty interactions very often, and infectious disease or infections are something which is very commonly prevalent, and skin being the mirror of this, I thought I would add some spice to this talk. So my previous colleague and senior doctor has already taken the SSTI, so I would be fair enough to speed up the topic. Now, rash with fever. Fever itself is a mystery. Rash again is a mystery. And we are dealing with both the mysteries simultaneously. So my aim is just to differentiate how when these two conditions are coexisting, and then appropriate line of treatment with differential diagnosis. So rash with fever, a very common problem that can vary from a simple one to an early manifestation of a life-threatening disease. Most of them are due to infections, and that's why we are dealing with this today. Fever, to define its temporary rise in the body temperature, response to some disease or illness, while rash, it's again a temporary eruption of the skin, which may vary from discrete red spot to generalized reddening, may or may not be associated with itching. Different types of skin infections, bacterial, viral, fungal, warts, impetigo, and their presentation or the classification which has already been dealt with in the previous one. Here I would like to emphasize on type of the basic lesions. If we can identify the exact lesions, then definitely it helps in clinical differential diagnosis. So a macule, which is a non-palpable circumscribed fat lesion less than 1 centimeter, papule, which is a palpable solid elevated lesion less than 1 centimeter, maculopapular, where there is a combination, pleomorphism is seen. So here we find erythematous rash comprising of macules and papules both. Purpuric patches or lesions are macular, which are non-blanching type of lesions. Nodules are relatively deep-seated lesions with size more than 1 centimeter. Plaque is a palpable elevated lesion with more than 1 centimeter. Vesicle is a fluid-filled lesion with less than 1 centimeter, and bulla is a fluid-filled lesion more than 1 centimeter, while pustule is a pus-filled vesicle. So with this simple definition, we need to classify them. And many times we find more than one type of lesions coexisting in the same patient at the same site. So what are the few things when patient present with fever, rash and history taking, which is important for us to understand? Exposures with any ill contactants in home or in care, traveling history, history of contacts with the pets or insects, medications and drugs, immunization, and the features of rash, how its progress, whether there is a temporal association, progression and evolution of the lesion, location and distribution, and associated symptoms. In physical examination, we would like to look for the pattern of the lesion, whether it is symmetrical or asymmetrical, whether morphologically they are monomorphic or pleomorphic, and configuration wise, whether they are group lesions or annular lesions, and at the same time presence of Kibnerization, that is presence development of the isomorphic lesion at the site of injury, which could be in the form of scratching. So these are some photographic view of some patterns of lesions. So these are linear rash, then we have annular rash, then we have this type of Kibner phenomenon. So how to differentiate between all these presenting complaints? So basically when we are differentiating fever with rash, we would first like to identify what type of lesion is this, and then probably would group them the underlying causes. So in maculopapular rash, macules are pinkish or reddish discrete flat areas with which blanches on pressure, while papules are solid raised lesions which can blanch on pressure. It could be due to viral infections, variety of viral disease including this measles, rubella, roseola, EBV, And amongst the bacterial infection, we have this erythema marginatum and scarlet fever, erysipelas, other SSTIs caused by staphylococcus and streptococcus. And amongst the rickettsic infection, we have this typhus and other conditions like Kawasaki disease and drug reaction which can present with maculopapular rash. Diffuse erythrodermic lesions are thickened scaly lesions which are present predominantly on palms and soles. That could be manifestation of these bacterial infections like SSS, toxic shock syndrome or scarlet fever. Amongst the fungal infection, it could be due to candidial infection and other systemic conditions or other forms of vasculitis like Kawasaki disease. Urticarial rash, again very common, specifically in pediatric age group. Again in this season, we find that there are transient swelled lesions which appears and resolves rapidly. It could be due to underlying viral disease, bacterial infections, and certain drugs may cause to this type of lesions. There may be vesicular, pustular or bullous lesions which could be again due to a certain group of virus like herpes group of virus, varicella, Coxsackie virus which are known to cause this type of vesicular and pustular lesions. Then amongst the bacterial, the bullous variety of impetigo can cause the vesicular or pustular lesions in the initial phase. SJ syndrome, 10 in the early phases may have this type of presentation. Petechial and purpuric type of lesions which are non-blanched red or purplic spots which are mostly associated with atypical measles or congenital rubella syndrome or CMV or enteroviral infections. Amongst the bacterial, they are the presenting complaint of meningococcal septicemia which is though unusual but life-threatening. And erythema nodosum like lesions which are tender nodules which may be due to the exudation of blood and serum which are having some underlying infections in the form of EBV or HBV virus. Bacterial, amongst the bacteria, the Mycobacterium tuberculosis is one of the commonest causative organism, and other fungal, specifically deep fungal infections like coccidiomycosis or histoplasmosis, specifically in immunocompromised patients. Now, I would like to discuss few case scenario. A 9-month-old girl, good general health, progressive fever for 5 days, coryza, exudative conjunctivitis, severe cough and irritability with no diarrhea, no vomiting, no recent travel history, and rashes appearing on trunk, abdomen and back, which appears 4 days after the onset of fever, and no itching, no blanching. So from the clinical, it looks very much clear, and on examination also one can make it out that there are confluent maculopapular rash all over the body. So the first differential diagnosis would definitely be measles, and very common in this age group. So we know the etiopathogenesis and the causative organism and the mode of spread. Another the phase of measles again divided into 4 phases. We all aware the incubation period, prodromal phase, exanthematous and recovery phase. Now, the specific changes which we observe in conjunctivitis, macular rash, this type of widespread macular rash with head to toe transitions are very commonly seen, and the presence of Koplik spot will confirm the clinical diagnosis of measles. Other manifestations in a complicated one, we can have cervical lymphadenitis, splenomegaly, abdominal pain with mesenteric lymphadenopathy, pneumonia, diarrhea and hepatic involvement can occur, but uncommonly. Investigations, we all know it's can be serological antibody test. IgM will help to identify, and chest X-ray to rule out the interstitial infiltration may be done. And diagnosis is purely clinical. Very rarely we rely on serology and viral culture or wait for the viral culture and PCR to establish the diagnosis. And complications which can occur in this: acute otitis media, interstitial pneumonia, myocarditis and pericarditis, encephalitis, SSP and mesenteric lymphadenitis can occur with this proportion in terms of complications. And the management part, good thing about most of the fever with rash is we have to just wait and watch in majority of the condition, and the symptomatic treatment is there. So maintain adequate hydrations, IV antipyretics if high grade fever, and high dose of vitamin A supplementation, and in the preventive aspect the MMR vaccination until unless the patient is severely immunocompromised. The other differential diagnosis is rubella, which may also present with the same presentation. So how to differentiate between this measles and rubella clinically? Here the rash will begin from the face and spread down to the body and can last for 3 to 4 days. Forsheimer spots, they are the key diagnostic features for rubella, and for this measles we have this Koplik spot. So there may be mild pharyngitis, conjunctivitis, anorexia, headache, polyarthritis with low grade fever in case of rubella. And we find this type of erythematous maculopapular discrete rash, while in case of measles there may be confluence of the rashes and the Forsheimer spots may be seen. Investigations all non-specific. We will look for the routine CBC and look for the serological test, and rarely complicated compared to the measles. Congenital rubella syndrome, we all aware the infant or the neonate may present with this type of rashes, and there are no specific treatment required, just give supportive care, and for congenital rubella syndrome baby should be isolated. Preventive aspect, again the MMR vaccine will definitely help. So to differentiate between measles and rubella, here rash is present in both, fever is there in case of measles more commonly compared to rubella. Characteristically there will confluent macular rash and Koplik spots are the hallmark for measles, while maculopapular discrete rash and Forsheimer spots are the hallmark for rubella. Both are by droplet transmission mainly, and symptoms includes high grade fever with running nose, cough for 3 to 5 days followed by rash, while here in case of rubella, rash with minimal to no fever or toxicity. An infection can occur even without rash. And the spread of rash, the transition is in case of measles it starts on head and upper body and spreads slowly down to the feet over 7 days, while in case of rubella it starts on head and upper body and spreads quickly down to feet over 3 days. So just a few history taking parameters will help to conclude clinically. Another very common condition which we find is with fever with rash is erythema infectiosum, also known as fifth disease, also known as slap cheek appearance of rash. So this condition is caused by human parvovirus B19. Treatment is very supportive, and those with chronic hemolytic anemia and pregnant females are at risk for developing this erythema infectiosum. Clinically, a child will present with no specific medical history, low grade fever for 48 hours, attend school, no travel history, no pets. And vesicular rash, now this is another case. So here we find vesicular rash on trunk and face. So whenever the fluid-filled lesion appears in this age group, the first differential diagnosis is always varicella. Okay, so varicella or chickenpox, the commonest one. Human are the only natural host. Chickenpox is the primary infection, highly contagious among susceptible. Secondary attack rate is more than 90%. Previously it was thought that chickenpox occurs once in a while only in lifetime, but nowadays we are seeing it occurring recurrently at 3 stages. First in the childhood, second one in the middle age around 18 to 24, and third again in the adulthood. So it's not that this virus cannot reinfect. It is contagious for 2 days before to 7 days after the onset of rash when all lesions are crusted. Peak age 5 to 10 years, peak seasonal infection late winter and spring, transmission through direct contact, droplet and air, and incubation period is approximately 14 to 16 days. It is again a prodromal symptoms where fever will be there with malaise and anorexia. Characteristic rash, there will be small red papules which turns into erythematous papules to vesicles, ulcerate, crust and heal, which can take 3 to 4 days. So on which day you examine the patient, that is again more important to diagnose the varicella. The pattern of rash beginning on the trunk, followed by the head, face and less commonly on the extremities. Pruritus is universal and marked. Lesions may affect even the mucosal surface, and oral mucosa is very commonly affected. So these are the classical rash or presentation of varicella. Complication, uncommon in children, but can even get the secondary infection by streptococci and staphylococci. Pneumonia can occur, myocarditis, pericarditis, orchitis, hepatitis. They are all known complications that occurs in few populations. Congenital infection, the characteristically the neonate will present with a low birth weight with cortical atrophy, seizures, mental retardation, cataract and microcephaly, and perinatal infection can lead to severe form of neonatal varicella. Treatment is symptomatic, non-aspirin antipyretics, that is important, cool bath, careful hygiene, Antivirals may be required if diagnosed during the prodromal phase. There is no role of antivirals after 72 hours, and topical antivirals practically have very little or no role. Topical antibiotics are mainstay in case of pediatric age group. We have some newer molecules like ozenoxacin, which are non-fluorinated and topical antibiotic, which are very helpful for wide variety of preventing infections, super infections. Prevention, we have vaccine against it, so and passive immunity by can also be attained through this. Now, another common condition is HFM, that is hand, foot and mouth disease, which commonly occurs in children under 10 years of age, caused by Coxsackie virus of different strain, enterovirus EB71 and other enterovirus. That includes the poliovirus, Coxsackie, Eco and other enteroviruses. It is more frequently seen in summer and in early autumn. And clinically, the condition is moderately contagious, and it is the child is contagious during the first week of illness, transmitted from person to person by direct contact with nose and throat discharge, saliva, fluid from blisters, or stool of infected person. Incubation period is 3 to 7 days. Fever is often the first symptom in case of HFMD, followed by the blister and rash. Clinically, mild fever with a poor appetite, malaise, child may feel sick and frequently a sore throat. 1 or 2 days after the fever, painful sores develops in the mouth. They begin as a red small spot that blisters and often becomes ulcerative. They are usually located on the tongue, gums and inside of the cheeks, and the skin rash develops 1 to 2 days with flat or raised spots with blisters on the palms and soles, which are characteristically seen and painful. So child is unable to walk, so that is the presentation of hand, foot and mouth disease rashes. Yes. It is, complications are uncommon, and enterovirus may be associated with some neurological complications like encephalitis and aseptic meningitis. Treatment is symptomatic. Dehydration is a concern that can be taken care, and very rare but severe is meningococcal disease, which can be caused by N meningitis. Transmission is through a respiratory droplet. This colonization of the upper respiratory tract penetrate into the bloodstream. Then this organism go to CNS and cause meningitis. Here the cutaneous signs. Here the maculopapular rash are the early features, often on a painful joint or a pressure point. And then it turns into petechial rashes in 50 to 70% of the cases, where they are distributed at trunk and extremities and purpuric spot, and then they start necrotizing. Non-cutaneous presentation may be altered mental status and neck rigidity. So this is how over the joints we find this type of purpuric lesions. So they are suggestive of meningococcal infection. It can be life-threatening in short duration. So to identify it in early phase is very important. Another clinical case, very good general health condition, 7 years with onset of sore throat for 24 hours and fever, abdominal pain and episode of vomiting, no rhinitis, conjunctivitis, hoarseness, coughing, and no recent travel history. So scarlet fever, which is caused by group A beta hemolytic streptococci, can be one of the commonest condition. Rash will appear 24 hours after the fever, can begin below the ears, neck, chest and stomach, and then spread within 1 to 2 days all over the body. And the condition look like a sunburn, or it gives a sandpaper appearance. More apparent at skin fold of the elbow, armpit and groin area, and this rash may last for 2 to 7 days. There may be flushing over the face, and fever may be mild to moderate, high grade with swollen lymph node. So in body folds, we'll see this type of presentation. So in body folds, especially the armpits and elbow, fragile blood vessels, capillaries can rupture and cause classic red streak, that is known as pestia lines. This may persist for 1 to 2 days after the generalized rash has gone. So these are the presentation in case of scarlet fever. Diagnosis, throat culture, CBC and penicillins are the drug of choice. Kawasaki's disease, form of vasculitis, which is characterized by fever for 5 days together with any of the following findings. Important to understand is the rash, where the redness or swelling of the hands and feet with generalized skin peeling is seen, and typically we see the strawberry tongue appearance. It's an idiopathic form, but importance is it may be associated with cardiovascular complications in the form of coronary artery aneurysm. Typhus fever, a rare condition, but still arthropod-borne rickettsial infection can be caused by this louse bite to human, and Clinically, headache, chill, fever, stupor, muscle ache, swollen lymph node and skin rash in the form of macular or petechial papillovesicular or all type of pleomorphic rashes can be seen in this type of infections. Infectious mononucleus, we are seeing so many cases of EBV infection and transmission usually through oral contact, and fever, malaise with tonsillopharyngitis, lymphadenopathy and petechia on the soft palate. That could be the initial or the first sign, and we see maculopapular rash associated with splenohepatomegaly in many of the cases. So this type of small rashes are there. Looking to the size of this maculopapular rash and the looking to the palate and the tonsils, it may be helpful in diagnosis clinically. Yes. And the roseola infantum, also known as sixth disease, also caused by HHV virus 6, disease of infant and children, very common but self-limiting disease below 3 years of age, and with a short incubation period. There are associated systemic complaints, but on the day 5 of fever appearance, generalized erythematous macules on trunk and neck are seen, which can be considered as a hallmark for this condition. Face is usually spared, so that helps to differentiate it from the other conditions. Very rare to see complications, and symptomatic treatment and supportive care is there. And the last one is eruptive pseudoangiomatosis, which is caused by ecovirus, majority cases in children, and they mostly occurs following organ transplantation. Mild fever with GI symptoms and rashes are seen. Diagnosis, it may require histopathology. And GCS, that is Guillain-Barré syndrome, not directly due to virus, but it is by the stimulation of the immunological system following a viral infection. So acute onset of rash with RTI diarrhea, with or without fever and malaise, and rash, pinkish or reddish papillovesicular rash of 1 to 2 millimeter associated with mild itching may be seen. And see, this type of papillar rash are seen over the mostly acral part. Treatment is self-limiting, but symptomatic treatment with topical steroids may be required, and antihistamines are the mainstay. So that resolve within 2 to 8 weeks. So there are so many rashes associated with it, but I just tried to put the common one and few of the uncommon one and the differentiating features from the all. Thank you.
Thank you, sir. Thank you for making it so simple to understand and remember rash with the associated infections. Sir, it's an honor to have you here. May I please invite Dr. Sankharva sir to present a memento to Dr. Chetan Lal Setha. So, I'll now invite Dr. Yagnesh Popat for the next session on resurgence of pertussis in India. Sir is a fellow IAP awarded in 2014. He's a chairperson presently of Infectious Disease Chapter IAP. He has been National Vice President in 2018 of ID Chapter, National Executive Board Member IAP 2009 and 2013, President of IAP Gujarat in 2006, President of IAP Rajkot in 2004 and 5, and President of IMA Rajkot 2000.
Good morning, friends. In next few minutes, we will be talking about the pertussis disease and its resurgence, especially in India. Friends, before we talk about the resurgence, let us recapitulate some of the facts about the pertussis. It is a gram-negative road organism. Human is the only host, and the incubation period varies from 6 to 21 days. The duration of illness is longer in comparison with the other illnesses. It is 6 to 10 weeks. And the expected recurrence, or the epidemiologically expected resurgence, is almost 3 to 5 years when the huge number of susceptible hosts becomes collected. The pertussis is the underreported disease, about 40 to 160 fold less than the actual cases. This is very important. We will come to some of the reasons why it is so much underreported later in the subsequent slides, but it is a hugely underreported disease. Asymptomatic cases are 4 to 22 times more commoner than the symptomatic cases. This is a very typical whoop that you see with the pertussis. Friends, low physician awareness, inconsistent case definition. The case definition varies from region to regions. So inconsistent case definition, under consultations, everybody will not seek the consultation, even if to the doctor, under diagnosis, even if diagnosed, under reporting, and wide disease variability. There is a huge variability of various presentations as far as the pertussis is concerned. And there are, on top of it, there are atypical forms of pertussis. So all this together leads to a underreporting of the cases of pertussis, and we see only 1 to 35% of the pertussis cases which are the reported cases. They are just a tip of the icebergs. Pertussis is on rise. In Australia, the reported new cases increased more than 100 times from 1991 to 2011. In California epidemics of 2010, over 9,000 cases, which was highest over last 60 years. In 2012 epidemics in Washington, a rate of disease exceeded that of even of the California epidemic. In United Kingdom, 10 deaths were reported in infants under the age of 12 months in 2012, which was highest mortality ever since the 1982 with the advent of the vaccine. So no doubt there is a resurgence of pertussis despite of availability of good vaccines. So what is the burden of pertussis across world as well as in India? These are the various reported cases globally from 1980 to 2019. As you can see, the number of cases were very high initially. With the advent of vaccine, the cases has started coming down, but over a period of time, it has either remained steady or in between, there is even increase in number of cases. Now, what is the situation in India? Initial situation almost same, high number of cases of pertussis. With advent of vaccine, it is coming down, little slower than what we observed in the globally, but it is definitely coming down. Thereafter, there was almost steady, but since last couple of years, it is still decreasing. So Indian trend is little different recently. So what could be the pertussis burden in India? If we look at the pertussis burden way back in 2012, we had about 320,000 cases of pertussis reported. And as we move ahead of 13, 14 and further down, the cases has definitely decreased from 320,000 to recently 11,000 plus cases in 2019. Now, if we look at the recent pertussis epidemic worldwide, United States, more than 40,000 cases 2012, Argentina, again a huge number of cases in 2011-12, United Kingdom, more than 8,000 cases in 2012, Australia, ongoing epidemics with intermittent further exacerbation since 2008, where 38,000 plus cases in 2011, again similar situation in the New Zealand. This is the national surveillance data of pertussis from 1922 to 2017. At various points, the vaccines were introduced. When DPT was introduced way back in almost early 1950 and 60s, there was decline in the number of cases of pertussis, sharp decline. Then there came the DTaP, acellular vaccine. There was initially steady, but later on there was some increase after the decline of Tdap, after the introduction of the Tdap vaccine. These are the different countries, the situation of pertussis reported cases, the one with the marked stars, that is out of the almost 20 countries, more than 50% of the countries is showing a rise in number of cases of pertussis. How this happens? Primary vaccination of an infant, child is protected, leads to a booster vaccination, there is a prolonged protection, but if then there is no further boosting of the immunity, immunity wanes, and there is a collection of susceptible adults later, which acts as a reservoir for the infection, and later when their number increases, they transmit the disease to the susceptible infants. So, what could be the reasons for resurgence? There are many reasons or many theories which has been postulated. One cannot blame any particular reason, but there are a huge number of different varieties of reasons which has been suggested. Number one, increased awareness amongst the healthcare workers as well as the caregivers. This leads to an increased reporting. So, this also will lead to an increased number of cases. Improved surveillance and improved diagnostic facilities. The surveillance is improved, you get more number of cases. Diagnostic facilities is improved, so you diagnose more number of pertussis cases, and that is why case number has increased. Inadequate vaccination schedules or inadequate compliance with them. There is recently there has been an increase in the either vaccine hesitancy or a group which are anti-vaccine. So, their number increases in certain geographical areas, especially in US and UK. So, that leads to incomplete compliance to the vaccination. Lower than desired vaccine efficacy. Though this is a debatable point, I will not go in detail of it, but we'll come to it in subsequent slides. Weaning of vaccine or infection NDS protection, because it will definitely not give a lifelong protection, or there could be a emergence of new beta pertussis strains which are resistant strains. So, there could be a number of reasons, but the bottom line is that we need a most effective vaccine or even more effective vaccine than what we are using. So, what could be the various strategies to curb this resurgence? Number one, repeated boosters. It has been suggested every 10 years, maternal vaccination, so that the infant does not get a pertussis disease. Cocooning strategy, vaccination of all those adults in the surrounding who are taking care of the infants in the family should be vaccinated beforehand, before they come in the contact of the infant, is also one of the suggested strategy. Newer vaccines is the another choice. So, these are the multiple factors we had already seen. More diagnostic facilities, more reporting, weaning immunity, gathering of unvaccinated population, increasing their numbers, and the change in the organism. We have more number of diagnostic tests, culture tests, PCR tests and serological diagnostic tests which are available over a recent decade or so. This has definitely led to a more diagnosis of pertussis. Another issue is the pertussis strains, whether the vaccine strain and the strains which are there in the society, whether they match or not. The pertussis outbreak in the several industrial countries, they were using acellular pertussis vaccines since 1990s. It was not for a year or two. Since 1990s, they were using those vaccines. Then the circulating B pertussis strains have undergone significant genetic changes compared to the pre-vaccine era strains and the wholesale vaccine strains. The beta B pertussis strains shows a genetic selection for vaccine escape mutants with the changes in vaccine antigen expressing genes increased virulence of the pathogens. The genetic divergence of circulating beta B pertussis away from the vaccine reference strains led to an allelic mismatch and rapid emergence of the protectin deficiency. So adoption by the pathogens likely from the vaccine pressures, increasing vaccine used, has led to a divergence of vaccine strains from the circulating strains. The antigenic LAs in the current acellular pertussis vaccine in comparison with the current circulating B pertussis strains, if you look at the USA, the vaccine strains match in certain areas and it does not match in the other areas. The genetic adaptations occurring through the allelic changes on the surface proteins. As we will see in the subsequent slides, the B pertussis have different antigens on different varieties of antigens in the surface and the allies and others, like this will come in the subsequent slides. So if there is a mismatch between these vaccine strains and the circulating strains, it will cause a issue. The pertussis bacteria is also muted over a period of time, which has led to an upsurgence. Another issue is weaning of immunity. So this is the picture I was talking about. There are a number of antigens against which we have a variety of vaccines. The whole cell vaccines have a different antigens, acellular, all are different. Some of the acellular vaccines have monocomponents, some has 2 components, and some have more than 2 components in their armamentarium. So these are the various antigens: fibria, protectin, filamentous hemoglobins. They are important components against which the vaccines have a protections. So multiple virulence factors are responsible for the pertussis pathogenesis. So if we talk about the acellular vaccines, they have limited antigens in it, like FHA, fimbria and protectin, while whole cell have a number of components within the vaccines. These are some of the important antigenic components which are missing in the acellular vaccines. Acellular vaccines, in the last figure it is seen, contains different varieties of antigens like protectin, FHA, fimbria, while this many components are missing. Next point is weaning of immunity. The duration of protection with the vaccine, both acellular and the cellular, varies. How it varies? When the Australian outbreak was studied, a pertussis reporting rate between 1999 to 2011 by the primary course of pertussis vaccination, and where so when the vaccination status were studied, only few of the cases where there were pure DTWP vaccine was used had a disease, while more number of cases were seen with the DTAP vaccine. This was also suggested that if we prime with the WP vaccine, then the immunity is better. Canada studies showed the effectiveness of pertussis vaccination and the duration of immunity. Duration of immunity means 10% every year. This was another meta-analysis where the several pertussis vaccine trials have shown a significant difference, no significant difference between DTAP and DTP vaccines. This was another studies where there is pertussis resurgence in England and Wales were also studied. The duration of protection for natural and WP-induced immunity was at least 15 years. However, with the acellular vaccine, it was found to be as low as 5 years. But the bottom line was the WHO recommended countries using WP vaccine for primary immunization should not change to the acellular vaccine. So this was the degree of protection. Natural infection 3.5 to 12 years, WP 4 to 15 years, and acellular 3 to 5 years. This was the another study where acellular pertussis vaccine effectiveness was studied over a period of time. This also came to the same conclusion that the initial efficacy of acellular vaccine is definitely high, but it wins faster in comparison with the whole cell vaccine. This was another study, national outbreak of pertussis in England 11 and 12, also concluded that AP3 and AP5 vaccines provide shorter duration of protection than the WP vaccines, and they also suggested that the AP3 is, if associated with increased risk of confirmed pertussis than with the WP vaccinees. And of course, the follow-up was shorter for just 5 years, so it should be definitely increased. So winning of immunity, better long-term protections against the pertussis disease seen with the whole cell vaccines, same conclusion. Why there is a winning of immunity with the acellular vaccines faster than the WP vaccines? Immunologically, it has been suggested that immunity following a natural infection or following the WP vaccines, there is a stimulation of Th1 and Th17 cells, while with the acellular, there is a stimulation of Th2 cells. The Th2 cells will lead to a lesser immune response, lesser memory. So acellular vaccines, instead of acellular vaccines have a shorter period of protection. We will not go into the detail of immunology because it will be a lecture in itself if we start an immunology talk. So WP priming is associated with a higher proliferative capacities and does not lead to a winning of pertussis specific memory T cells. WP based vaccines provides Th1 and Th17 polarizations, thereby longer duration of protections. AP containing vaccine stimulates Th2 response, which gives a shorter term protections. Th17 responses are the robust responses following natural infections and WP vaccination, but this is absent in the AP vaccination, and boosters given with AP priming do not give a longer lasting immunity. So this is same long-term protections. So there are few shortcomings of the acellular vaccines: suboptimal efficacy, shorter duration of protection, less priming, and lack of quality immunological response. So to summarize the facts about the acellular pertussis based vaccines, mutation in the pertussis bacteria may be responsible for the resurgence. There is comparable initial efficacy of the acellular vaccines, but may have a faster winning of immunity and reduced impact on it. Has a reduced impact also on the transmission, less effect at the limiting and clearing the mucosal infections, and they induced a different type of immune responses. What is WHO position? Protection against severe pertussis in infant and adult can be obtained with the primary series of either of the vaccines, WP or AP vaccines. Available evidences indicate the more rapid winning of immunity with AP vaccines relative to WP vaccines. However, WHO clearly says that national programs currently using epi vaccine may continue to do so, but should take care of the additional booster doses, while the national programs which are currently administering WP vaccines should continue with the WP vaccines. Thank you.
Thank you for making us aware of the current scenario of resurgence of pertussis infection in India and ways to prevent it. May I request Dr. Chirag Patil sir to present a memento to. Thank you, sir. We now move on to a panel discussion on rational investigation practices. From the era of diagnosing a patient on the basis of history and clinical examination, we have moved further to the era of depending more on investigations. So let us learn how to be rational. And for this, I would like to invite our panelist, Dr. Kirit Sisodia sir, from all the way from Surat. Sir is a pediatrician and neonatologist at Surat. He is the president of Surat Pediatric Association presently, co-opted member IAP ID chapter presently, and HOD Department of Pediatrics, BAPS Hospital, Surat. His areas of interest include infectious disease, vaccinology, and adolescent medicine. He has been organizing secretary, West Zone Pedicon, GIAPCon, past executive board member, AOP Gujarat, faculty at Pedicon and State Conference, and author of Target 5 and has various publications in national journals. I invite Dr. Mehul Mitra sir from Rajkot. Sir is a senior pediatrician at Rajkot. He did his MD in 1990. He is in private practice since last 30 years, and he has been the pioneer in the Saurashtra region for intensive care practice. He has been past president of AOP Rajkot, organizing secretary for various conferences, workshops, and seminars, has more than 300 lectures, and he has been very active for the public awareness. Published a book on childcare in Gujarati known as Tips for Childcare. I would invite now Dr. Jhankna Sanghvi, senior pediatrician at Rajkot, our president of Academy of Pediatrics, Rajkot branch. Ma'am is also HOD at DNB Pediatric Department of Padma Korba Hospital, and she is a consultant at her hospital, Lifeline. And now I invite Dr. Jai Dhirwani. Sir is a pediatrician at Rajkot, at Amrita Hospital and Samanvai Hospital. He has been president of Indian Academy of Pediatrics Rajkot and Academy of Pediatrics Rajkot, vice president IMA Rajkot and Academy of Pediatrics Rajkot, honorary editor for IMAX, the official magazine of Academy of Pediatrics Gujarat and Jimacon, honorary secretary of Academy of Pediatrics Rajkot in past 2006 and 7, and executive committee member, Academy of Pediatrics Gujarat and Rajkot. I welcome you all. To moderate the session, I invite Dr. Digant Shastri, sir. Thank you.
So, good morning once again to all, and I welcome my expert panelists. They are all practicing pediatricians and also attached with teaching programs like DNB. So, in next 45 minutes, we will be discussing about rational investigation practices in pediatric infectious disease through some case scenarios. I request all the panelists to be very brief, have a crisp answers, as well as our basic aim of today's discussion is not to diagnose a particular condition or to discuss about that particular condition, but the basic aim of today's presentation is to convey a message regarding the rational approach of diagnosis. So, how best we can use the diagnostic modalities, and in this case, this presentation will be having some day-to-day case scenarios. They are real life case scenarios, they are not fabricated cases. So, there may be some approaches which may be wrong also by that contributor of the case. So through this we will try to convey the message to the audience regarding how one can be rational. So firstly, why we should be knowing about, or why we should be discussing about the rational investigation in PID. So we all know that for a general pediatrician, the infectious diseases are accounting the high tool load in their practice, and if we have an early diagnosis of these infections, it will naturally affect the outcome. There will be a positive outcome. It will be helpful in reducing the mortality as well as morbidity. As well as if we have a early diagnosis, then in that case we can contribute in prevention of drug resistance, because if we have a correct diagnosis, probably we will be using the appropriate antibiotic therapy, and that will prevent the emergence of drug resistance. At the same time, we all know that there is a significant advancement in the diagnostic modalities are there. Many new methods are now available. You have rapid fire, but the cost of rapid fire, this biofire films, all this is quite high, and many times you may have limited information, or even you may have information which may, if you don't interpret it properly, you may in fact over-treat it. So you have a issue of too much and too many, and how you can use that rationally or in a best way, that is to be learnt. So we have to be about rational in diagnosis, and by that way we can avoid irrational practices. So with this brief outline about the theme for today's discussion, let us start with a case scenario. Case number 1. It's a month of July where a current 5-year-old child has come with a high-grade fever with chills for 2 days. He has associated headache, nausea, vomiting, no other symptoms. Child was taken to the general practitioner. Some tablets were given. Was advised to take the medicine with the milk. And with this background, the examination findings were patient was febrile, ENT examination was normal, spleen was just palpable, and rest of the systemic examination was normal. Oh, sorry. So, Mehul, what is your provisional diagnosis and how will you proceed? As I said, we will not be focusing much on the diagnosis part. We will be mainly focusing on how to proceed further in investigating this case and how we can reach to the diagnosis. Yeah, over to Mehul.
Good morning, friends. Am I audible? July month, one of the positive point, high grade fever, another positive point with short duration of illness, 2 days only, nausea, vomiting, headache, and most important than all of this is spleen palpable. In the month of July, the first possibility I would put is either malarial fever or second dengue fever. With considering these two common during these months, back of the mind I would like to keep an eye on CNS infection also. If child deteriorates or if something doesn't come out positively during the investigation or in next few days, if some clinical features pertaining to CNS will come, I would keep a close eye on this. So with that, I would like to investigate for malarial parasite. I would send a peripheral smear for MP, NS1 antigen and CBC.
Right. So, rightly said by Mehul that we have to consider the epidemiological factor, that is the month of monsoon, and monsoon maladies are usually seen during these months are viral fevers, all sort of viral fever. It could be even influenza, dengue infection, or it could be malaria. And country like India, where salmonella infection is also pandemic, so we have to endemic. So we have to think of the salmonella also. But because the short duration of history, we will not go for all the investigations in the beginning. And in that case, as Mehul Bhai said, that we will go. Sorry, આમાં કઈ issue થાય છે? Yeah. So as he said, you will go for the complete blood counts, which can give you the information regarding the total counts, differential counts, as well as malarial parasite is very, very important. And since the child is a young child, you have to think of possibility of UTI also. So urinary tract infection, for a screening of that, you will go for a urine routine and microscopy examination. Mehul, another question to you, that if you are thinking of malarial parasite and malaria as a possibility, will you prefer to go for a microscopy or a card test, which is handy and you can get the result very fast? So what is your choice, and you can justify your choice?
Yeah. Personally, I would go for both, as I am practicing in Rajkot. I have an access to a good pathologist around whom I can ask for good peripheral smear. Still, as we know, peripheral smear for malarial parasite is a gold standard. So that is a choice of investigation.
Yeah.
But sometimes if we don't get a good pathologist or a good person staining the slide also, or if pathologist is not available around, or if the chances of getting the report late, we can also send card test for or RDT for.
Yeah, so in short, the take home message is very clear that for diagnosis of malaria, still the peripheral smear is the gold standard. But there are many situations where you may not have a qualified, means a good pathologist who is accustomed of detecting the malaria parasite, as well as if the pathologist is busy practitioner and he is not putting enough efforts to find out the malarial parasite, then probably in that case your card test may be of utility. So Dr. Jankna, if you have to rate between the microscopy and the card test, how will you rate these two tests, both the tests?
Microscopy is a gold standard. RDT has some limitations because it does not quantify parasite. It cannot detect the stage of parasite. It's little bit expensive, and it detects only the gametocytes. And when a viral load is, parasitic load is very low,
Right.
sensitivity is less. So this is the RDT limitations over the microscopy. But RDT is helpful when the severe parasitemia, but like a cerebral malaria, when there is a sequestration of the blood.
Absolutely right.
At that time, RDT is better than microscopy.
So in short, if you have to rate between these two, then naturally the card test has got some limitations, which mentioned by Dr. Jankna, that if there is a low parasitemia, it will be a false negative, as well as it cannot give you the species diagnosis and the concentration of the parasite, based on which the prognosis of the patient you can predict. So these three are the common limitations of this test. But the thing is that if you are in the emergency situation where you don't have the pathologist available, or there is a emergency where you need to have an immediate diagnosis bedside, in that case definitely you will go for the card test, right? And about the peripheral smear, few things we will like to update to the audience. That firstly, please remember that no need to go for the wait for the test, preparing the peripheral smear for fever to be on the peak. It can be collected at any time when the patient is febrile. It should always be prepared before you start the anti-malarial, and prepare both the thick as well as thin smear, because both are needed for the species identification as well as your quantification of the malarial parasites. For the site of the collection, it can be from the finger tip or from the ear lobules, and you can prepare the slide from the venous blood also. But if you are preparing the slide from your EDTA bulb, then it is to be prepared as early as possible from after collection of the blood, maybe within 2 to 3 hours. Otherwise, the RBC pathology morphology will be changed, as well as the parasite detection may be less. So now, Dr. Jai, I know you are involved with intensive care also. So suppose a patient, same patient came in the middle of the night with history of convulsions and altered sensorium. In that case, how will you go ahead? Will you go, or will you wait for peripheral smear, or you will go for the card test?
Good morning, everyone. So the patient is critical. It's an odd hour, and if my diagnosis, provisional diagnosis, is cerebral malaria, then I would definitely go for. I mean, at this time comes the importance of rapid diagnostic test, because at such an odd hour, the qualified pathologist may not be available to look for the PS, and rapid, as the name itself indicates, rapid diagnostic test will give me the rapid result, because which is very critical for me to start the specific treatment for the disease. So, and even rapid diagnostic test is important where the qualified pathologist may not be available even in the daytime, like in the peripheral centers.
Yeah.
And sometimes even in the cerebral malaria, because the sequestration of parasites is there, the peripheral smear may be negative. So in such scenarios, rapid diagnostic test scores over the peripheral smear.
Yeah, and we all know that the cerebral malaria diagnosis means the prognosis is directly related to the diagnosis and early initiation of the appropriate anti-malarial therapy. So suppose a patient who is from the remote area, again there is no facility of the laboratory, or when you are referring the patient from remote area, the patient has come to you with the convulsion, altered sensorium, and before you are referring to the higher center, you need to give the first dose of anti-malarial, and in that case, naturally before starting anti-malarial, you will like to go for the diagnosis. So in that case also, again you will go for the rapid diagnostic test. But please remember that if you have a strong suspicion of the malaria, and if your rapid diagnostic test is negative, in that case, you should attempt for the diagnosis of malaria by offering the peripheral smear for the malarial parasite, right?
So the vice versa is also true?
Yeah, vice versa. See, it is as we are always telling that the rapid diagnostic test are microscopy are the gold standard. So vice versa will not be applicable. But if you have a rapid test which is you are thinking that negative, and in that case you are strongly suspecting, then naturally you should go for a parasite by smear.
Vice versa is true when patient comes to you, and before that, if any 1 or 2 doses of anti-malarial are given, at the time your peripheral smear might be negative and you are in dilemma to diagnose. At the time, antigen can be present in the blood and you can diagnose by antigen test.
So, but what I means message I think we will like to convey to the audience is that microscopy is the gold standard, and there are, I think I request the cameraman not to focus on my face. You can just allow the slides to appear on the screen, or you can put my picture in the PIP rather than the whole screen, right? So already we have covered about what are the advantages of microscopy over rapid diagnostic test. So we will not go into the details of it, and we will go with the case number 2. The case is of 3 months old child, high grade fever, chills for last 2 days, irritability, poor feeding, occasional vomiting, no otorrhea, no upper respiratory symptoms, and child has been treated with amoxicillin for this 2 days fever with irritability. On examination, child is febrile, hemodynamically stable, SpO2 95%, there is a bulging fontanelle, otoscopy is not done, no neck stiffness, no meningeal signs, and other systemic examinations are normal. So, Kirit, with the presentation of short history of fever and this poor feeding, irritability, no meningeal signs, but bulging fontanelle, how will you proceed?
Can we?
This happens.
Okay. So, 3-month-old child with a high-grade fever without chills and poor feeding, irritability, occasional vomiting, and on examination there is fever, no other localization sign for the fever, only bulging fontanelle is there. So in that case, we would suspect that patient is having an 3-month-old child with either a respiratory tract or gastrointestinal tract infection, or it would be a systemic bacteremia or urinary tract. When there is a no localization, chances of septicemia or urinary tract infection would be there associated with bulging fontanelle. So that would be a meningitis, or malaria would be possibility of last diagnosis would be there.
Right. So in short, it is difficult to jump to any clinical possibility with this given history and given finding. But the one condition, UTI, again one has to keep it in mind, because it is quite common in the young children, and they usually present with all sort of different symptoms, including fever, refusal to feed, vomiting, and they are not necessary that the patient may have a typical history of difficulty in micturition, right? Okay. So in the given case, the following investigations were done: complete blood counts, peripheral smear, urine routine microscopic culture, and lumbar puncture was done. In all suspected cases of pyogenic meningitis, one should invariably go for the CSF examination, particularly if you are going to start an antibiotic, because in a young children, if you avoid or if you delay the lumbar puncture and start empiric antibiotic and then you go for the CSF examination, it will alter the CSF picture. And the CSF should be examined within 30 minutes of the performing the lumbar puncture. Otherwise, you may have a cell lysis and you may have a false low total count on the CSF. Also, you should go for the sugar investigation, that is the sample is to be collected in the fluoride bulb and send blood sugar just before performing the lumbar puncture.
So here I would like to say, whenever in our hospital we are used to do a lumbar puncture, we first alert the laboratory that we are performing the lumbar puncture and pathology should be. Whenever there is an odd hours are there, we just inform them in advance, and then after we are doing a lumbar puncture. So that should be protocol. Sometimes when we send the sample to the laboratory in odd hours, pathologists are not present there, and then the morning reports come which might be the false negative.
Yes, so I still remember our residency days where we used to do the puncture and then the IMRC will go to the laboratory once in the night or maybe twice in the night after all the samples are collected, and that too she will go to one lab for collecting the report, then she will go and deposit the sample to the microscopy laboratory. So we at that time we are not aware that such things can lead to a false negative laboratory results, right? So Kirit, as I said, if in this child I wanted to start antibiotic, I should have gone for the lumbar puncture, but there are conditions where we have to delay the lumbar puncture. So can you enumerate the conditions where we should delay the LP?
As you rightly said, before starting the antibiotic, when you suspect the meningitis or a smaller kids, you should always do lumbar puncture. But there are certain conditions when lumbar puncture might not be the possible or it is contraindicated, as like an patient come with hypovolemia or patient is in the shock, or there is a signs of brainstem herniation, as like an unequal pupil would be
Right.
there, or there is a severe respiratory distress. So these are the some condition when you have to start or when you have to delay the lumbar puncture, or there is an papilloedema or decerebration are there.
So in short, the hemodynamic stability of the patient is first criteria where to be eligible for the lumbar puncture. A child who is hemodynamically unstable, if you go for the lumbar puncture, probably you may end up with the complications. Similarly, a child who has evidence of raised ICT in form of papilloedema, unequal pupils, or decerebration is that. Again, in that cases, if you go for lumbar puncture, then again you may end up in a problem. So better if such conditions are there, you avoid the lumbar puncture. Now, Jai, the question is to you. If the lumbar puncture is to be delayed, then what else can be done?
So if the lumbar puncture cannot be done because of these conditions, then we can at least send the blood cultures, and
Right.
then we can start the empiric antibiotic treatment. And if possible, if the child's condition permits, we can go for this contrast CT.
Right. So basically, you can go for you should go for blood culture and try to find the means microorganism responsible for this bacterial meningitis. At the same time, now we have the contrast CT facility available almost at most of the places. So in that case, if the patient is hemodynamically not that unstable, and if you can send the patient for the contrast CT, then you can send it and you will get the information. Dr. Janknaben, you have done means patient was hemodynamically stable, patient has been CSF studies performed, and what test you will like to order, the routine studies for the lumbar puncture?
Yes, for a routine CSF examination, I would like to see the complete cell count, CSF sugar, protein, gram strain, CSF culture, and a rapid agglutination test for the H. influenzae, meningococcal, and a pneumonia.
Right. So there are many tests now available, but our usual tests are cytology examination, which can differentiate between bacterial meningitis. It can differentiate between bacterial meningitis and viral meningitis, or aseptic meningitis, or a tuberculous meningitis. And also you will go for the sugar and protein. So if you have these three parameters, based on that you can definitely differentiate between these three conditions. At the same time, gram stain, like a meningococcemia, you can have a gram stain. Similarly, latex agglutination test you can go for. PCR also you can go for various organisms, and culture. It should be invariably done, and it should be sent, because the chances of getting positive culture will be better. Dr. Mehul, you want to add anything?
Yeah, I think we should try to collect little more sample and ask the laboratory to preserve it. If at all we want to go for some other tests, then we can order after this report.
Right. So in the given case, when the CSF was done, it was showing 40,000 RBS, 5,000 WBC, 60% polymorph, sugar was 30, blood sugar was 80. So CSF protein 200, gram stain negative, and latex test for H. influenza, S. pneumoniae, meningococci negative, culture is awaited. And the WBC count is 18,000 with 78% polymorph. So from the picture, what is likely possibility?
40,000 RBCs and 500 WBC. First possibility is of a traumatic CSF. Gram stain negative with a CSF for 200 and CSF sugar is 30. So identification of organisms with a gram stain become negative if it's a partially treated bacterial meningitis. The first possibility is a traumatic LP, or is a
Right.
partially
So
treated.
very well said by Dr. Janknaben that this is likely, and particularly traumatic lumbar puncture is quite common in younger children, and you can, based on the WBC RBC ratio, you can definitely differentiate between whether it is a really traumatic tap which has led to so many RBCs or some other pathology. At the same time, if you think that this is a traumatic tap, in that case you can repeat the tap after 48 hours. So, right. So, again I will not go into the details of this table basis, because this table I think you all must have seen at several our modules of IAP, based on the parameters like total cell count, sugar, protein, and ADA or lactate, this thing, how can you differentiate between pyogenic meningitis, aseptic meningitis, partially treated meningitis, as well as early TBM. So, I won't go into the detail for the sake of the time. So, let us ask Dr. Mehul Bhai, will you go for a repeat lumbar puncture in each and every case, or you have some criteria for, or selective cases you will go?
Usually if child is responding well, clinically is fine, signs of increase in tractional tension is going down, and clinically child is becoming less febrile, conscious level is improving. I think repeat LP is not required. Only when the child is not responding well, or there is very poor response or no response, if you want to change the antibiotic, then only we should repeat lumbar puncture.
Right. So, the take home message is very clear that in all routine cases you don't need to have a repeat LP examination. Only cases which are fail to respond to your appropriate antibiotic therapy as per the likely pathogen, as per the likely age group based pathogen, if you have started the antibiotic in a correct dose and still if the patient is not responding, in that case definitely, and if you are planning to change the antibiotic, in that case invariably before changing the antibiotic you should go for the repeat lumbar puncture examination. So, let us move to case 3. Kavya, 3-year-old female, fever for 4 days, no localization, history of constipation, examination normal, your CBC is normal, malarial parasite negative, and uncentrifuged urine shows 10 pus cells per millimeter cube. Jai, will you label this as a case of UTI?
No, sir. I will keep the possibility of UTI, but you cannot label this case as a pure, confirmed case of UTI, because uncentrifuged urine can show up to 5 to 10 pus cells. Even in the febrile pyuria, there could be 5 to 10 pus cells, fewer maybe because of any cause. So, only on the routine and microscopy, we
even a febrile child also may have a this thing, pyuria.
Yes, febrile pyuria, fewer because of any reason, there could be 5 to 10 pus cells in the per HPF.
Yeah. So then, how should we stamp a case of UTI in
urine culture sensitivity? That is the only gold standard for diagnosing.
So the message here is that just merely on the base of pyuria on urine routine examination, one should not label it. We have seen many our colleagues starting antibiotic just based on, and our pathologist colleagues, they many times highlight 5 or 7 WBC in a bold letter, and then the parents ask, sir, what is this? Ye kya hai? And then our colleagues, they make a round around it and they start the antibiotics. So the message is very clear for all such friends that based on this just WBC on the urine examination, we should not label it as a case of UTI. It can just raise a suspicion about possibility of UTI, and you should further investigate such case and only label it if you have a urine culture showing this thing, organisms, right? But here we have all the different tests which can give you the different sensitivity and specificity. So pyuria it has got sensitivity of 72 to 85%, while specificity is only 48 to 82%. Similarly, there are urinary nitrite test, leukocyte esterase test. These are the rapid tests which are strip tests which are available for performing at the bedside. Again, they all also have the limitations ranging from 45 to 60 and 85 to 98%. The gram stain of urine again has got a good specificity and sensitivity, but unfortunately none of us perform that test in our clinical practice. Again, word about rapid test, it is having chances of false negative if there is a insufficient time for the incubation of bacteria in the urine, by which it will give the positive test. Similarly, if patient is having frequent urination, then you may have a false negative. And the organisms which are not containing nitrite reductase enzyme, in that case again you may have a false negative urinary rapid test. So again these tests should not be done. So gold standard for diagnosis of UTI is a urine culture examination. Based on the method of collection, again you have to see the colony count, that you can go by suprapubic puncture. Of course, I don't know how many of us are performing. Maybe in neonates or a young infant, some of us may be doing, but in grown-up children, none of us try it. Then urethral catheterization and midstream clean catch sample collection. That is the most commonest way. So based on the way of collection of the sample, the cutoff value for the colony count is there. For suprapubic aspiration, any colony count, any number is having probability 90%, while urethral collection 5 into 10 raised to 4, then 95% possibility, and in midstream collection 1 into 10 raised to 5, then there are about 90 to 95% possibility of urinary tract infection. Right. Kirit, can you, okay, Mehul bhai, you want to?
Just from the history, one important point was there in the history that child had constipation. Constipation increases the stagnation of urine, and that may contribute to the increased cell count.
Right. So again, when such history is there, again, before you treat the UTI, at the simultaneously you have to treat the constipation also. Otherwise, the child may have a recurrent same problem. Kirit, can you just tell about the collection of midstream sample? How best we can collect it, or any one of you?
First of all, you have to for midstream it is clean catch sample. So most commonly used sample method collection for the urinary tract infection. So you have to clean the external part of the penis. Then while streaming the urine, you should allow the first some sample to be passed, and then after at the mid portion you have to collect sample and directly immediately without touching the inside of the container you have to send it to the laboratory immediately. And if you are not able to send the sample immediately, you should refrigerate the sample.
Right.
And second thing, for the collection of the smaller kids, it's a very difficult, because we usually tell the parents that a 6-month-old child or a 4-month-old child, we just take a clean catch sample. But how long they will hold the patient to collect the midstream or clean catch? They don't pass when you want to desire or you want to collect. So at the time, suprapubic tapping is important to collect the sample.
Absolutely.
So you rapidly tap over the suprapubic part with the finger, and that is the by that or rapidly tapping in just 5 or 10 minutes, baby will pass the urine, and at that time you should collect it.
Yeah, so in fact we have to educate to the parents when particularly the sample is to be collected from home and then transported to the laboratory, and at the same time there are many bags are available, but please remember that collecting the urine sample in the urine collection bag is only permissible for performing your microscopy, but not for your culture sensitivity. So another question to you, Kirit, about suppose in this case the first episode of UTI was diagnosed. The patient has got colony count of more than 10 raised to 5, and this is the first episode of UTI. So, how will you proceed in this case?
So first of all, we have to treat the patient according to the culture sensitivity of the antibiotic, and meanwhile all the patients of urinary tract infection with the first episode, you should go for the ultrasound examination. What you're looking in the ultrasound examination is any renal tract anomaly or any kidney anomaly is there, any hydronephrosis is there or not, what is the bladder size and the texture of the bladder, that should also be noted, as well as any renal stone or calculi that to be noted, or any renal structure, how is the corticomedullary differentiation. If all these things are normal, you can stamp as a normal ultrasound, and by after that, if anything is abnormal, you should do for MCU as well as DMSS con, irrespective of the age. But if anything, everything is normal found in the scan, so if child is less than 1 year, you should have a high index of any anomaly which cannot be detected in normal ultrasound, and you should go for MCU as well as DMSS scan. If child is between 1 to 5 year, you should first perform the DMSS scan. If it is normal or no scarring will appear, then you should go for no investigation is required. But if it is DMSA is abnormal,
Right.
you should go for a MCUG, and more than 5 year, no further investigation is required. So timing of the other investigations of MCU and DMSA is also important. So MCU should be performed after 2 to 3 weeks of the acute episode, and DMSA is to be performed 2 to 3 months after the episode of the urinary tract infection.
So in short, see, this is a very clear guideline by IAP Nephrology Group, which is published in the Indian Pediatrics. Based on the age of the child, after the first episode, you will decide what is to be done. If the child is less than 1 year, you will go for both MCU as well as DMSA. If the child is between 1 to 5 years old, in that case, in spite of normal USG report on the first episode, you will go for a DMSA. Many times, again, I will like to highlight here to the audience that DMSA is a one test which is probably underutilized by many of us. It is not that it is not available at most of the places. Nowadays, it is available at most of the places, but still we are somehow feeling shy of using this test. So, in age group of 1 to 5 years, if normal scan is there, you will go for a DMSA, and if there is a scar on DMSA or the DMSA is not available, then you go for the MCU. While irrespective of the this thing, abnormal USG scan warrants both MCU as well as DMSA, and Kirit has already told about the timings for the performing this test. MCU after 2 to 3 weeks and DMSA after 2 to 3 months.
Here,
Right.
I would like to one more point. When you go for MCUG, it is usually after the treating the patient, after 2 to 3 weeks, you go for MCUG. We better advise to take 2 days antibiotic, 1 day before and 1 day after of
Or
the
even-
MCUG to prevent an invasive bacterial infection, because it is an invasive procedure.
Yeah. I think I have been told by the organizers that we have 5 more minutes and we have 2 or 3 cases, so we will quickly go through. Saira, 5 years old female, moderate fever for 4 days, nausea, loss of appetite, vague abdominal pain, no chills, rigors, loose motions, rash, respiratory symptoms. And examination finding, patient is febrile, mildly pallor, ill looking, spleen just palpable, rest examination findings are normal. So he is a 4 days fever, loss of appetite, abdominal pain is there, no other findings, and ill look is there. So Jai, what could be the provisional diagnosis and what test you will like to order?
So looking at the history and the clinical examination, the few provisional diagnosis that I would like to put in is dengue fever, malaria, because the spleen is palpable, then enteric fever also, and maybe a certain prolonged kind of viral infections.
Right. So it is very difficult from the short, because it is a 4 days fever and there are vague presentations. The patient does not have any localizing sign. Vague abdominal pain, again, how much to take it means give importance to that, it is not very clear. So all these infections, dengue, malaria, even dengue also will have abdominal pain. We know dengue also will have a nausea. So malaria also can have all these symptoms. So in short, these are the possibilities, and the investigations performed in the given case are CBC, peripheral smear, MP, NS1, urinary routine microscopy, blood culture, and also perform typhoid. Any comment about typhoid?
As useless as Svidal.
Right.
So most widely misused.
Absolutely. So the lab results are again not much conclusive. NS1 is negative, typhoid is IgG is positive, which is going to be there, and IgF negative. Urine routine microscopy normal, blood culture not collected. So in this case, there is no clue. You are not getting any clue because total leukocytic count is not pointing towards anything. Urine examination is normal, so probably you are ruling out UTI. Possibility of dengue, again NS1 is negative, but still you cannot absolutely rule out it. Eosinopenia is there, so can be a typhoid, but again that is not a specific finding. And malaria, your peripheral smear is negative. Still, if you have a strong suspicion of malaria, you should go for a repeat peripheral smear examination. So patient was hospitalized, started with empirically ceftriaxone, culture was sent. On day 3 of admission, fever persisted, no clinical improvement. So, Mehul bhai, શું કરીએ હવે?
Number one, wait for the culture report to come.
Right.
From the history and counts and eosinophils, the first possibility here goes in favor of enteric. So blood culture is the gold standard, so we should wait for the report of blood culture. Another possibility, dengue again can be negative initial phase, we should repeat it. Same with the peripheral smear, sometimes we may get false negative, so we should repeat that also.
Right.
So these three should be repeated. I mean.
So in short, Kirit, anything else you want to add?
If it is an enteric fever, within 48 to 72 hours, you can find a clinical improvement after starting a ceftriaxone. Majority of patients, not all the patients.
It may take some time. Even there may be some improvement, but at the same time, the defervations may take 4 days, 5 days, even 7 days also.
Usually the main duration is 3.7 to 7.8 something.
Yeah, so in short, the message is very clear that if you are suspecting enteric and if you have started in the correct dose ceftriaxone, in that case, don't expect a dramatic response in a 2-3 days treatment, and you just need to reassure to the parents about, and if the child is generalized well-being is there, no need to be panic, and you have to consult to the parents. So apart from blood culture, the USG abdomen also can be of help. Even it can be of help in detecting the gallbladder edema, which is a features in the dengue also. So that you will go for it. So yeah. So Mehul bhai, while collecting the blood culture, any specific precautions you will
the sample should be, number one, the sample should be adequate enough. That is number two. Number one is before starting the antibiotics. Number two is sample should be adequate, that is roughly more than 5 ml. And the broth and blood proportion should be 5:1 or at least 10:1.
Right. So in short, the enough quantity of blood should be collected, and for small children, the ratio should be 1:5 to 1:10, and preferably start before starting antibiotic. But even if you are suspecting enteric, the yield will be better before starting antibiotic. But even after starting antibiotic also, if you are suspecting, you should not avoid it. You should definitely collect it and transport the sample at room temperature. See, for other many cultures, we are telling that it should be transported in a refrigerated condition or between 2 to 8 degrees centigrade. But here you should ask to transport it at room temperature, and always ask for the nalidic acid sensitivity, right? And as we know, the yield is highest in the first week of the illness. As the time goes, the blood culture yield ratio will go down. But still, even if patient comes at 7 days, still you should go for the blood culture study in the suspected cases of Salmonella infection. The bone marrow culture is having high yield even in the late phase of the illness also. But again, it is not feasible in each and every setup. Kirit, I think you have already, but just you can give a one word about ordering Vidal or Typhidot.
Definitely not advised, because the poor specificity and false negativity is so much common. And the first week during which we required the most results, at that time it is negative, so it is of useless.
Right. And again, same, both Typhidot M and Typhidot, they are a modified form of Vidal test. So they are just giving the, Mehul bhai.
Yeah, I think Typhidot will start coming positive after 3 days. Vidal will be after 7 days.
Right.
So as a supportive evidence we can utilize, that is what I feel.
So we will just conclude with this case which was started with ceftriaxone in dose of 100 milligram per kilogram. The blood culture turned out to be positive for Salmonella typhi, which was sensitive to the third generation cephalosporin. So we had started with the right antibiotic. Patient became afebrile on day 6 of the therapy, and later on, as per the protocol, patient was switched over to the oral cefixime and was discharged home. Thank you very much to all my panelists. Thank you very much to the audience, and thank you organizers for giving the opportunity.
Thank you, sir.
Thank you to all the panelists. May I please request Dr. Srimankar sir to present a memento to Dr. Mehul Mitra and Dr. Kirit Sisodi. May I request Dr. Swati Popat to present a memento to Dr. Jhankna Sangvi and Dr. Jai Dhirwani. Thank you to all the panelists for making it interactive and lively. Thank you, Digant sir, for moderating the session. Now we also have a tea break, but that will be simultaneous with the session. So we won't take a break from the session. So please help yourself. Tea is being served at the back. Moving on to the next session. The next session is by Dr. Raju Shah sir on multi-drug resistant typhoid management. Dr. Raju Shah sir is a medical director at Ankur Institute of Child Health, Ahmedabad. Former professor and head, Department of Pediatrics, GCS Medical College, Ahmedabad. Various posts held in the professional bodies in the past. National President, IAP. President, Pediatric Association of SARC. Chairman, Committee on Immunization, IAP. Chairman, Infectious Disease Chapter of IAP. Various awards and publications include Dr. Ashok Kapse Oration Award, Dr. Shantilal Sheth Oration Award, Editor-in-Chief of IAP Textbook. Over to you, sir.
Morning, friends. Well, continuing from the last session, the last case of enteric fever or typhoid, I'll now give you some details about the MDR typhoid, because in our country, since almost last 15 years or so, whatever typhoid we are seeing, they are all MDR typhoid. So it's always an issue. So what is the burden of this typhoid that we are getting? If you look at the global burden, we are seeing almost 11 to 22 million cases per year. So it's a big number. And this number is high in third world countries and Asia Pacific countries. Not only the morbidity is high, even the mortality is also fairly high. And we are seeing almost 14 lakh, 1,45,000 to almost close to 1.6 lakh deaths per year because of the enteric fever. And Delhi's, if you consider, it's almost 10 million. So in Asia Pacific, there is a big burden. Similarly, part of Asia being India also has a very high burden. And it is almost 30 to 40% of the burden of world is reported from India itself. So if you look at the number of cases per lakh population, it comes to almost close to 500 to 700 cases per 1 lakh population, which is considered to be the highest over the world. When we are talking of typhoid, we are forgetting the paratyphoid. But paratyphoid is now reported much more than what it was reported in the past. And this is the surveillance for enteric fever in Asia that has reported almost 77 cases per 1 lakh population per year in Central and the South Asia. So global, this is the paratyphoid, 6 million cases per year. And if you look at the India, around 20% of the enteric fever cases, they are paratyphoid cases. Morbidity and mortality is also fairly high. And even if you compare this to the other world countries, the morbidity and mortality in India is also fairly high. This is the report from communicable disease in 2017. So, is the third most common cause of morbidity among communicable disease in India. Is responsible for almost 4% mortality among the deaths due to the communicable diseases. And without treatment, mortality in typhoid fever is as high as to 20 to 30%, which is reduced to around 1% with effective antibiotics. The mortality is higher in children. This is the most important part. This disease is known even in the adults also, but if we compare to the Indian, age-wise group, it is the younger children who are suffering more, morbidity is high, as well as the mortality is high. And if you look at the global age-specific mortality rates, this is what the mortality, and if you look at the bar here graph, that tells us that the mortality is much higher in the pediatric age group as compared to the adults. And if you look at the younger than 5 years of age, it is around 17.2, and children less than 15 years, it is 59.3%, that is the mortality. So, if you look at the incidence of typhoid age-wise, again the morbidity, that is the incidence, is much higher in the pediatric age group, and this is how the bar tells us that the children have the highest incidence of typhoid fever. Till almost last decade, the impression amongst people was that the typhoid fever is less common in children less than 2 years, and it was considered that disease is more in the age group of almost 5 years and above. But now with the surveillance, we have realized that this disease is also very high in children between 2 to 5 years. Not only that, it is also now reported much higher in children less than 2 years. And this is how, if you look at the age group of different, in the month wise, you will find that even the less than 1 year also, there is a fairly high incidence of the enteric fever reported now. So, one of the major reason why the typhoid vaccine is now recommended in children less than 2 years by WHO as well as our IAP, ACVIP. So, there are many dilemmas in managing the enteric fever. Just now we heard about the investigations, and so it is the lab diagnostic dilemma is there, but along with that there is clinical dilemma also, because how to make a diagnosis is always, because this is a one condition where there will be a fever without focus. And not only that, there are many atypical presentation of this disease. So, there is a clinical dilemma, we have lab diagnostic dilemma, and as well as treatment dilemma also, because we have now this MDR, and not only that, just we have heard that the defervescence time in the management also has increased to almost more than a week or so in many cases. So, these are the dilemmas. So, what are the issues in clinical diagnosis? The issues that, as I said, that fever without focus is the commonest presentation, but not only that, there are many cases that will present with abdominal pain, other abdominal symptoms, bloating, as well as the diarrhea. Some children may present with respiratory symptoms also. So, probably our focus will go to the respiratory system and not enteric. Some of them, they will present with hepatosplenomegaly, also jaundice, also pain in abdomen, and some of them, they are also presented with burning micturition. So, these are atypical presentation, and that gives a dilemma. Very few cases are seen as, standard book picture, like step ladder pattern, coated tongue, rose spots, and relative bradycardia that we normally used to read in the books, but nowadays they are hardly reported or seen like this. So more uncommon type of presentation is seen and less that standard book type of presentation see. That is why it make even create problem in the diagnosis of the disease or clinical diagnosis. If you look at the case definition of typhoid, this is what has been described by the WHO: probable suspected case or confirmed case and chronic carrier. So these are all classical books, so I don't go into the detail. But one must remember that, as rightly pointed, that positive serological tests are not recommended for the diagnosis of enteric fever and are not included in the definitions of typhoid fever. So here, if you look at the definition, it is the confirmed case by culture which are included as the confirmed case. So that was about the clinical picture dilemmas. If you look at the lab diagnosis dilemma, again, just to reiterate that gold standard is a standard blood culture, and sensitivity varies between 40% to 90%. If it is done before giving antibiotics and within first week, probably it is fairly high, up to 70 to 90%. Clinical perception is that Vidal is easy to do, but the sensitivity and specificity in the endemic areas is very poor, and one cannot demonstrate the rising titer because one is not ready to wait for the second test to come and then start treatment. So that is why this test, though it is a high sensitivity, but it cannot be done. And Typhi-dot again is an unpredictable test and not recommended by anybody. So for diagnosis of enteric, the gold standard still remains as the blood culture. So that's very important. Culture yield just now was shown in the slide. Again, same slide is there, that first week bone marrow has a highest yield or sensitivity, but normally we don't go for it. Blood culture is fairly high, so on third or fourth day, if you have taken blood culture, chances of getting positive is as high as almost 70% or so. And let me remind you that Salmonella is very easy to grow. So with the availability of culture media now, if you have sent the blood culture, probably chances of getting it positive will be almost as high as 70 to 90%. Treatment dilemma, again, as this we know that this is a MDR typhoid now in our country. So how do we treat? Whether you should treat with monotherapy or a polytherapy, because many a times, as rightly pointed out, that even with starting the right type of treatment, effervescence takes almost 7 to 8 days, and many clinicians get uneasy when fever lasts for more than 4 or 5 days. But let me remind you that there is no advantage of using the polytherapy. Single drug monotherapy is very good, and one has to persist with that. Do not use fixed drug combinations, do not use aminoglycoside, or do not use the BL-BLI combinations in managing the enteric fever. The duration of treatment is very important because number one is the increased defervescence time, which is as high as 5 to 6 days in most of the patients. So one has to wait till then, and so now the recommendation is that minimum we have to give 14 days of treatment, or at least 72 hours after the defervescence. So whichever is longer and not shorter. So suppose the defervescence has taken 12 days, then probably you'll have to continue for 15 days and not only for 14 days. The relapse rate, in spite of the right type of treatment as per the culture, still is as high as 8 to 10%, and this relapse rate is higher with the cephalosporins, especially continuing with oral cephalosporins. And if we, unfortunately, if somebody has stopped the treatment earlier, then also relapse rate will be higher. Fortunately, even if there is a relapse, it responds well to the first line of antibiotic or the same antibiotic to which child has been treated. But most important will be the appropriate duration of treatment, that is more than 14 days or so. we are always talking of the resistance, and fortunately, though these are multi-drug resistance, the latest reports, even in the last few years, the ceftriaxone is still sensitive to the tune of almost 98% or so, and that is why it remains the drug of choice. There is an increasing resistance to now seen in last few years to azithromycins, and there is a reversal of sensitivity to or increasing sensitivity to the first line drugs, that is chloramphenicol, clotrimazole, as well as to the amoxicillin. So that's a positive point that is going on, because there is no drug pressure, because we have stopped prescribing these drugs in the enteric fever for quite a long time. Other treatment along with the managing the antibiotic will be use of antipyretics properly, maintenance of hydration, and appropriate nutrition. And not only that, prompt recognition of the symptoms and treatment of complications, and the appropriate and for a proper duration of therapy will be important. So these are the drugs which are used, and these are the doses, and with this dosage, this is what the relapse rate will be there. This is just book picture, and this table is available in all the books. So currently preferred drug of choice in management of MDR typhoid in our country is also the third generation cephalosporins. If the child is hospitalized, you have to treat with the parenteral drugs like ceftriaxone is the first preferred drug, or cefotaxime can be a second, and in few cases you can use even cefoperazone. Orally they can be managed with cefixime, or in some cases even with the cefpodoxime. Preferred drugs, parenteral is ceftriaxone, and oral will be cefixime. Relapse rate, as I said, it is still there, but again, starting the same drug, you can manage these patients very well. These other secondary line of treatment in real failure will be either azithromycin or aztreonam. Azithromycin RCT shows that efficacy is almost equal to ceftriaxone, and it is superior to chloramphenicol and the fluoroquinolones. The aztreonam trial shows a longer time of defervescence compared to the ceftriaxone and chloramphenicol, and this drug is mainly for treatment of severe or complicated enteric, or those who are allergic to the ceftriaxone or cephalosporins. The empirical treatment will be like this. If the local resistant pattern is not known to us, that for outdoor, you start with cefixime 20 milligram, wait for 5 days, clinical improvement, continue for 14 days. If no clinical improvement and culture is inconclusive, then consider changing it to azithromycin for almost 14 days or so. If it is a patient who needs hospitalization, ceftriaxone will be the drug of choice. If culture shows that there is a sensitivity to clotrimazole or chloramphenicol, probably you can downgrade to this either clotrimazole or the chloramphenicol, and you have to continue drug for 14 days. Second line drug will be aztreonam or azithromycin. Combination therapy is not advised. There is no advantage at all, so refrain from using combination. In relapse, again, continue with the first line which had responded well. The relapse are generally milder and responds to same drug. Alternatively, one can change to azithromycin. It's a good option for treating. Complications are seen affecting almost all the organs of body or systems of body. Relapse rate is 5 to 10%. The commonest complication that one can see is the intestinal hemorrhage or perforation in second week, and cardiovascular and neuropsychiatric complications also are reported in enteric fever. Multi-drug resistance typhoid is a bigger issue now, and it is more reported from Asian countries. If you look at the graph, Pakistan has the reported very high degree of resistance, and they are almost to the tune of XDR type of typhoid reported there. They were 22% of their cases reported from 2 districts of Pakistan. Fortunately, still India has very, very low this type. So MDR typhoid in India is less than 10% still, but ciprofloxacin or ofloxacin resistance has increased now almost as high as more than 80%. Now, though ceftriaxone resistance has not increased, there is an increasing resistance to azithromycin. There are few cases reported of XDR also from India, and they are one from Delhi, one from Calcutta, and also from the southern India also. So there are few case reports of MDR. So the prevention is the most important way of treating the child. By public health measures, one can prevent the disease, but it's not a good way. Best way would be the vaccination, because it is more affordable, doesn't require behavioral change, and it is a cost-effective type of management. So the available vaccine at present are VI vaccine, both types, conjugated with tetanus toxoid and conjugated with CRM 197. They are available. They are conjugate vaccines, all these different brand names, they are available. The schedule is single dose VI conjugate typhoid at between 9 to 12 months of age. Booster is not recommended at present. Catch-up schedule up to 18 years of age, single dose. WHO position paper tells that there is, at present, there are no data available which can, so they are almost not telling whether booster should be given or not. But they say that single dose should be quite okay after 6 months and in adults up to 45 years. So to summarize, enteric fever is a public health problem in Indian subcontinent. Increasing XDR strains in Indian subcontinent, which is threatening the treatment. Third generation cephalosporins are still the preferred drugs. Pediatricians should be aware of atypical presentations. Sanitation and hygiene can prevent to some extent. Vaccination with conjugate vaccine is the best way to prevent. And there is a need for vaccines preventing both Salmonella typhi and paratyphi. Research is on, and probably we may get in few years. Thank you. Thank you very much, friends.
Thank you, sir, for such a lucid presentation. It's always an honor to have you here and pleasure to listen to you. We appreciate your time and efforts and coming all the way from Ahmedabad. Thank you so much. I would request Dr. Rakesh Patel to present a memento to sir. Thank you, sir. As we move ahead, the next session is on fever with lymphadenopathy by Dr. Chetan Trivedi. Sir is a practicing pediatrician and neonatologist at Neha Children's Hospital, Kakaria, Ahmedabad. At present, he holds the position of Executive Board Member, Gujarat Central IIP. He is ex-honorary assistant professor and infectious disease consultant at UN Mehta Institute of Cardiology and Research Center. He has been past president of Academy of Pediatrics, Ahmedabad, member of Academic Council, Central IIP 1617, also executive board member, IIP ID Chapter 2017, joint secretary, IIP ID Chapter, author in various books. Over to you, sir.
Good afternoon, friends. At the outset, it gives a tremendously different feeling to be standing in front of you physically. Yes, it is a good feeling, of course, and good feeling because we are now gradually coming back to normal, and that's what is more important rather than anything else. So, thanks to ID Chapter IIP, AOP Gujarat and AOP Rajkot, Dr. Yagnesh Bhai in particular, for giving this wonderful opportunity to be here at Rajkot physically. So, today, a very interesting talk has been given. Why interesting? I'll be just narrating you. Fever with lymphadenopathy. And we know that as a practicing pediatrician, this is a very common condition which we follow, like we see in our day-to-day office practice. So why it is important, this topic? It is important for parents as well as for the doctors. Because whenever the parents, they see a node somewhere, ultimately they will be directly relating it to either a malignancy. And similarly, we as a clinician also would like to rule out that, kahin ye wo to nahi. And that's what we are worried. And that's why it's a very important topic. Now, what is the definition of lymphadenopathy? In general, if you say it's just an enlargement of the lymph node, it can be a proliferation of the lymphatic tissue itself, or it can be infiltration by something else, maybe malignant or phagocytic cells. So when there is a lymphadenopathy, it can be infective as well as non-infective, inflammatory as well as non-inflammatory. So if it is inflammatory, it is lymphadenitis, but it has been used this word synonymously. But it is not. Now, when you say lymphadenopathy, so enlargement, so how much enlargement is really an abnormal? So what is the threshold of abnormal, the enlargement? So it varies with the location. And when you say almost 38 to 45% of the pediatric population, we get a palpable lymph node. So when you get a patient with a palpable lymph node, that doesn't mean it is abnormal. We have to look at the site and what is the size. So what is the site? So in newborn, usually we hardly get any palpable lymph node. So if it is more than 1 centimeter, it is definitely a cause of concern. When you go beyond 1 month, and if you have a lymph node in axillary or cervical region, what do you see? If it is more than 1 centimeter, it is abnormal. If you see epitrochlear region, here even 0.5 centimeter and beyond is abnormal. And in inguinal, 1.5 centimeter is the cutoff to differentiate whether it is just a normal lymph node enlargement or it's abnormal. So this size, friends, it is important only when you are talking about a local lymphadenopathy, not for the generalized. If you have generalized lymphadenopathy, even less than this size also matters. So that is important. Now, so approach to case of fever with lymphadenopathy, that is what we want. And when we want to have an approach, our goal is to determine what is the underlying cause which affects the initial management. So we will go for a history and physical examination, we will have some clinical diagnosis, and then ultimately we will try to decide what to investigate and how to manage. So that is important, and that's why ultimately it is very important to reach to the clinical diagnosis first. And for that matter, I have tried to first enumerate the causes, because we have to know the causes. We know that it can be infectious, neoplastic, immunologic or metabolic, but out of that, in pediatric population, majority of the lymph nodes, they have been enlarged because of the infective etiology. Either it is a viral or bacterial, that's not mattering, or not very important, but it is infective. And we see certain diseases now gradually, HLH, Kawasaki, even Kikuchi or PFAPA. These are, different names now which we are becoming gradually familiar with this kind of diagnosis. So this is the routine causes of lymphadenopathy. Now, I have tried to derive one slide, and we will apply this 6 or 8 questions to any patient who comes to us with a fever with lymphadenopathy. Now let us try to understand what is there in the center. Center is age. Why it is important? As I said, in newborn you won't find a palpable lymph node, but if you have it more than one, it is abnormal. Then as you grow ahead, then if you have preschooler, early schooler, you have reactive lymphadenitis. That's normal, viral infections are common. Then you have a Kawasaki, that will be more in less than 5 years. Then if you go to, suppose a patient has inguinal lymph node, sexual transmitted disease, that is adolescent. SLE, these rheumatological conditions, they will be more in adolescence. So age is very important. Whenever you start asking the question, the age is important. Now, second is duration and a course of disease. What is it? And localized, generalized, unilateral or bilateral. Now let us try to understand what is about duration. Now duration, if the lymph node is enlarged less than 7 days, it's acute. It is 1 to 3 weeks, it's subacute, and more than 3 weeks is chronic. Now why we are worried about this disease duration? Because when you go from subacute to chronic, more chances of the disease which can be a generalized and systemic in origin. So there we need to act fast and we have to investigate further. Then course, whether it is a progressive, it is a constant, it is regressive, or it is intermittent. That is also important. Then localized or generalized. Now in general, when we talk about generalized lymphadenopathy, it is not that many lymph nodes all across the body. If it is 2 or more non-contiguous group of the lymph nodes which are enlarged, that makes our generalized lymphadenopathy. So if you have a cervical and axillary, if you have cervical and inguinal, that's your generalized lymphadenopathy. And when you talk about localized, it is usually drainage area is important. Something is there and then it gets enlarged. But it's generalized, there's more of a systemic symptoms, more of systemic reasons, and more of a generalized disease. So that's why that's the difference. And you might have to look at the, either it is unilateral or bilateral. I'll be just putting across a few cases that will give importance to whether it is unilateral or bilateral. Then let us go to associated with. So we have to ask certain questions and also exposures. So what are these? So if it is associated with upper respiratory tract sort of symptoms, URI, yeah, that can be viral, yeah. Okay, then we have a mouth ulcers. We have a patient with, mouth ulcers or a pharyngitis, dental caries. So that is infective etiology. Conjunctivitis, yes, we can have adenoviral infection. Constitutional symptoms, this is called typically B group of symptoms, where we have fever, malaise, then we have fatigue, weight loss, anorexia. These are the symptomatology. If it is associated, then it is more of a systemic disease. Arthritis, arthralgia, rheumatology, and skin rash may be viral or Kawasaki. So these are the symptoms, group of symptoms we have to ask whether it is associated or not. Exposure, animal exposure, ill context, immunization, medicines, Cox context, these all are important because that will drive your diagnosis towards certain particular group. Suppose you have a exposure to unpasteurized milk, then brucellosis we can think. Ill context, we can have a respiratory infection, HFMD. So they can be same group of patients in the same community. Cox context, very important. So this is about the associated with and exposure. Then let us go to lymph node characteristics. Now this is very, very important because this will definitely drive your diagnosis to particular condition. So site, single or multiple, size, consistency, attachment, tenderness, and skin changes. See, these whenever we examine, it should come all in this order, and we have to write on paper that this is this characteristic of lymph node. So anybody can look at it and can get a diagnosis. So let us go for a site. Now, if you know localized lymphadenopathy, most common is a cervical, followed by inguinal. So when you talk about the localized and cervical, these are the lymph nodes we have to see. Now these lymph nodes are important. We should not a single lymph node group. So when you talk about the cervical lymph node, we should examine from going behind the patient. Ask the patient to flex the neck, then you start palpating, start with submental, submandibular, go beyond this mandible, pre-auricular, post-auricular, occipital, then go vertical, deep cervical, and supraclavicular. So these should be the track by which we should examine, so we should not miss any, and that will help us in a diagnosis. Now, what are the lymph node groups other than cervical? So they are supraclavicular, we can have, as I said, axillary, epitrochlear, inguinal, popliteal. When you talk about axillary, popliteal, or inguinal, usually they are localized lesion, and that will cause the enlargement of that particular group of lymph node. But supraclavicular, this requires a special attention because supraclavicular on the right side will drain mediastinum or lung. So we have to suspect malignancy, and if it is left, it will come from abdomen. So it is a malignancy. So supraclavicular, you should always be very careful when you are examining that patient. So as I said, site, single or multiple, yes, it is important. Size I said, depending upon the site, it will be different. Consistency. Now let us try to understand consistency. If it is, say, when you are going from soft or soft consistency, usually a bacterial infection or infective. Then you go for firmer or harder, it is more towards the malignancy. So that is important. Then about attachment and fixation. See whether this node is been attached with the surrounding structure, surrounding lymph node, or it is attached to deeper structure, and that is whether it is fixed or not. If it is there, then it is more towards the malignancy. Tenderness. Usually we consider tender is infective. It is not the fact. Yes, it can be there, tenderness, even in there is a hemorrhage in the lymph node, it will be tender. If there is sudden or rapid rise of the size, then also capsule will be stretched and there will be pain. So it is not that synonymous with the infection. Yes, tenderness has to be sought. Skin changes, if there are some changes, because abscess development, you can see red or erythema. If you can violaceous red in case of non-tuberculous mycobacteria, so that is very important. Now, look at the other lymphatic system. Now, when we talk about the lymph node, it is not just the lymph node. Lymphatic system is made up of so many things that is like you have your tonsils and adenoids, you have thymus, you have the appendix, even Peyer's patches. These all are part of lymphatic system, and particularly the spleen and liver. So when you examine other lymphatic system, you have to look at these organs also. So never ever miss these three things: leukemia, lymphoma, and tuberculosis, because that's the real worry for all the clinicians. So, what are the high risks where you suspect this particular malignancy? Size more than 2 to 2.5 centimeters. If it is generalized, if supraclavicular, as I said, subacute or chronic onset, fixed firm to hard, non-tender to palpate, with associated with changes in the overlying skin or certain additional symptoms like a fever, a malaise, or a weight loss, or anorexia, and lastly the progressive course. So these are the high risk factors where we have to think about the malignancy. Now, so one should be very much aggressive when you have this kind of features in your investigation as well as the management. So finally, we have to look at these two things: failure of response to antibiotics, particularly in localized lymphadenopathy. We have to give the course of antibiotics for 14 days, 10 to 14 days, and look at the response and examination of drainage site, particularly in the localized lymphadenopathy. So now, applying this particular slide to each and every case, let us try to reach to clinical diagnosis. First, this is case number 1, 4-year-old girl presented with fever, moderate grade, painful swollen glands on the left side of the neck, noticed since last 3 days. Now, how should I progress? Now, let us see. I have put it in this. Duration and course, what is it? It is 3 days, so acute. Localized or generalized? You localized, unilateral. Associated with, yes, there was moderate fever, nothing more than that. Exposures, no exposures found. Lymph node characteristics, submandibular. It is asymmetrical, tender, soft, and somewhat erythematous. And other systems, no spleen, liver, no other lymph nodes palpable. Right? So this is the first case, and here I think we can safely put the diagnosis infective, and mostly our localized infective nodes, they will go for suppuration, because 1/4 to 1/3 of infected nodes, they suppurate and become fluctuate, and generally within 2 weeks of illness. So this is a routine course of that. So suppurative lymphadenopathy is usually, as we know, the group A, streptococci or staphylococcal, almost 80 to 90%. Submandibular is most common. Most children, they are less than 5 years, and there is a history of fever, odynophagia, otitis media, or impetigo. And if you have a periodontal infection, that is important because there the bugs will be anaerobe. So that has to be kept in mind. And yes, if it is localized, we should not forget Kawasaki. So let us go to case number 2. 5-year-old boy presented with fever which is high grade 7 days, swollen glands noticed left side of neck since 5 days, associated with redness of eyes, skin rash, cracked lips, red lungs. I think no points for guessing. And let us see this case. This patient, there is a node as well as the lips you can see. So let us put it in this slide. What is happening? Duration is 7 days, so subacute. Localized or generalized? Localized, unilateral. Associated with, yes, high grade fever and other features what I showed. Exposures, none. Lymph node characteristics, anterior cervical, asymmetrical, tender and warm. Other lymphatic system, no. So this gives a diagnosis because it is a subacute, localized, unilateral, and with other symptoms. So it is an immunological Kawasaki disease, right? So now case number 3, 6-year-old boy. Fever, enlarged neck glands, both sides of neck since 4 to 5 days, associated with ulcerative lesions in mouth, and there is salivation. Let us see, put it in. These are the pictures of the patient. I think here also diagnosis is very clear looking at the picture, but let us try to do the exercise. Duration? Okay, fine. Duration and the course is 4 to 5 days, acute, localized or generalized, localized bilateral, associated with fever, ulcerative lesions in the mouth. Exposure, yes, history of similar contacts in the family and the friends. Lymph node characteristics, anterior cervical, soft, discrete, mobile, shorty. Now, shorty is typical word which has been used. You know, it is a sort of marble-like consistency. So that is that will give a clue. No other lymphatic system involvement. So it is reactive lymphadenopathy. So whenever reactive lymphadenopathy, not necessarily it is only viral. It can be bacterial also. So what are the causes? Yes, it can be influenza, rhino, entero, adenovirus, herpes simplex virus group. Yes, it can be a, if it is long-standing EBV or CMV, or it can be a group A streptococcus. And here, modified Centaur criteria we can apply. There is a fever, odynophagia, exudative tonsillitis, tender lymph nodes, and absence of cough. That will give us a diagnosis. Now, case number 4, 7-year-old boy, parents notice enlarged node in left side of the neck since 6 months, having fever, malaise, tiredness in 15 days, no history of exposure, and multiple courses of antibiotic. Look at the patient. Now, let us see, 6 months, so chronic, localized, unilateral, associated with constitutional symptoms, no Cox contacts, lymph nodes, they are rubbery. Now here I have used the word rubbery. That is very typical of the diagnosis. There is a splenomegaly. So failure of antibiotics, we can put safely this is query Hodgkin lymphoma. Now case number 5, 3 years old girl with fever, low grade off and on, swollen leg glands, both side of neck, left more than right, few nodes 1 to 2 centimeters, associated with weight loss, weakness and anorexia, no response to antibiotics. Now look at the patient. This is left side, it is more prominent. Let us see what is the detail. 2 months, so chronic, generalized, yes, there are few nodes other way also. Constitutional symptom present, Cox contact is there, lymph node is gigulogastric, 2 by 2, matted, mobile, firm, non-tender, and there is a liver and spleen both palpable. So failure of antibiotics, so it can be a chronic infection. Maybe a tuberculosis more likely, maybe HIV or EBV. Now case number 6, 4-year boy, fever, swollen inguinal lymph node. This is for the first time for the change. Left side since 3 months. Constitutional symptom present. Inguinal lymph node matted, non-tender, mobile. No response to multiple antibiotics. So it is a chronic, generalized, with constitutional symptoms, Cox contacts, matted lymph node, and there are few cervical lymph nodes. So it is a generalized chronic. So diagnosis, this particular thing helps. MT positive, so it's a tuberculous lymph node, most likely. Yes, you have to investigate. This is after treatment, before treatment, after treatment. Fantastic response with the treatment. So what we have seen so far clinically, acute unilateral, yes, it is bacterial. Acute localized unilateral Kawasaki, acute localized bilateral viral or reactive, chronic localized unilateral we have seen, and chronic generalized bilateral. So it's a chronic infections. So investigation, what are the investigation will you go for? They can be a laboratory, maybe a CBC, non-specific. CBC is specific for atypical lymphocytes, all malignancy. Otherwise, yeah, infection, it will be more. ESR, CRP, LDH. LDH and uric acid more for malignancy. Microbiological, yes, depending on the case, you have to go for it. Mantoux test is important as far as lymphadenopathy, because 70% of tuberculous lymphadenopathy will have Mantoux positivity. Throat swab, blood culture, yes. Imaging is important. Sonography of local lymph node, with or without Doppler, CT scan, X-ray chest and MRI. One word about X-ray, whenever we have a lymph node, we want to go for biopsy and anesthesia we want to give, get an X-ray test done first, because we are not sure about mediastinal lymph node. 2D echo for Kawasaki, histopatho, FNSE or excision biopsy, Gram-stain, AFB, histopathological or CBNet. These are the compulsory tests to be sent once we are going for a biopsy. Now, role of ultrasound, yes, it is to differentiate between reactive and malignant, and excision biopsy versus final aspiration. Now, why this is important? Because excision biopsy is a gold standard. Because we need to have a good amount of the structure, sample, so we have to take a firmest and the largest node, and we have to take with the capsule intact. So that will give us pathological mycological examination as well as immunohistochemistry. And one word is materials to be sent in a formalin as well as normal saline, because gene expert will be positive for a normal saline, not in a formalin. So yes, indication is when you suspect malignancy or when you don't expect, get the result, when you expect it to recover. Fine needle aspiration, it is very difficult in pediatric population because the place is such and you are not able to do it. So that's why, and the sample size is also very less. So it is not the choice of investigation. But yes, when the surgical dissection is associated with high risk or non-compliance of patient, we can go for it. Now, this is a very important flowchart. I would like to just give a minute to it. Whenever we have a patient with fever lymphadenopathy, history and physical examination, if you have a strong suspicion of malignancy, what I said high risk, then directly you send to this person, onco people. Because if you waste the time in investigating, sometimes it will be very crucial. Then if you have certain diagnosis in mind, suppose superiority bacterial lymphadenitis, you treat it. If you have a suspected certain diagnosis, suppose you think infection mononucleosis, you go for investigation and then you confirm it. If it is confirmed, fair enough. Not confirmed, you go for biopsy. Suppose if you have anything which is unknown origin, that's a lymphadenopathy. If it is localized, I think here we can go for investigation as well as you can go for a course of antibiotics. If it responds fair enough, it is not, then it will go for a biopsy. And if you have unknown origin, but you have generalized. I think we have to go for all the sets of investigation, and if you don't find anything, you have to go for the biopsy. So this is the chart. This last case I will be just putting into it and then finishing. Yes, this algorithm is important for the tuberculous lymphadenopathy. This has been there in NTP program. We have to go through this. And this is the case, 4-year-old male child brought with complaints of swollen glands on the left side of the neck since 14 days. Occasional low-grade fever and child was playful. So let us put it in on this slide. What is happening? 14 days. So subacute onset, localized unilateral cervical, associated with no constitutional symptoms, exposure none, lymph node, cervical lymph node, non-matted, non-tender, mobile, overlying skin normal. So we are not getting anything. What is anything other lymphatic thing? Nothing. So here diagnosis, no, we are not sure about the diagnosis. So unknown etiology. So what we have decided, let us do that. First, investigation. Investigation also didn't rule out anything. So all the things are normal, say ESR, CRP, LD, USG abdomen, X-ray chest, everything normal. Then you go for a course of antibiotics and you check it. We have given a course of antibiotics. After 7 days, the patient came back because increasing size of lymph node. So we'll go for, a USG local part. Even that doesn't reveal much. There is some necrotic lymph nodes. So, and no evidence of perinodal inflammation, node abscess, cold abscess, nothing. Now I think we have the answer, that is the gold standard excision biopsy. So here the excision biopsy was done, and if you can see here, we got a lymph node which is polymorphous infiltrate of lymphocyte, and ultimately what we got the diagnosis is classical Hodgkin lymphoma. And here immunohistochemistry is very important in case of Hodgkin lymphoma because we have to type it. So this is how you apply the knowledge of the approach. So that's, again, I'll reiterating, never forget to send the tissue in the normal saline for gene expert. So to summarize, yes, a child with peripheral lymph node, goal is to determine underlying cause which affects the initial management. A cervical lymphadenopathy is most common in children. Almost 85% of cases of cervical lymphadenopathy in children are infective in origin. Answer the 6 or 8 simple questions that will lead to a etiological clinical diagnosis, and accordingly do go for the investigation, because further evaluation in form of investigation and management depends on the initial clinical diagnosis. Never ever miss leukemia, lymphoma and tuberculosis. So lastly, as I said, excision biopsy is a gold standard. So don't worry, you go for excision biopsy, you will get the clinical diagnosis, and that will help you to manage the patient. Thank you so much.
Thank you, sir. Thank you for the wonderful presentation. We deeply appreciate your time and efforts. Thank you for coming all the way from Ahmedabad. May I please request Dr. Neeta Ghiwala to present a memento to Dr. Chetan Trivedi. For the next session, I invite Dr. Yagnesh Popat on the enrichment of PCV vaccine armamentarium. Over to you.
Good afternoon, friends. Since morning we are hearing about the various diseases, its diagnosis, rational approach, management, how we go for it. And now let us have a look at one of the vaccine. This vaccine which I will be talking about probably did not receive our attention which it should, maybe because of corona pandemic, and we were too busy searching for the corona vaccines and utilizing those corona vaccines in our day-to-day practice. Of course, not in a private practice, but of course with the government license. Before corona pandemic came, we had 2 PCV vaccines with us, PCV13 and PCV10 by GSK, and the difference between 2 was the 3 strains, namely 3, 6 and 19A. During corona pandemic, another 10-valent vaccine came in the market by Serum Institute of India, so we will label it as new PCV10 just for the sake of differentiation. What was different here? The 2 strains, namely 4 and 18C, which were there is the old PCV10 has been removed. So it became a 8-valent. 2 strains out of the 3 extra strains that PCV13 had, 6A and 19A, were added. So again it became a 10-valent. So 2 old strains were replaced by the 2 new strains. This is the 2 new strains. So what are the importance of these different strains? Why some of them were removed, why some of them were added? Let us understand one by one each strains. When we had just previously available 2 vaccines with us, what was the WHO position on it? WHO clearly said both PCV10 and 13 have substantial impact against the pneumonia, vaccine type, invasive diseases, as well as the nasopharyngeal carriage. PCV13 offered additional benefits in settings where disease attributable to the subtypes, serotypes 19A or 6C is significant. So the choice of product to be used in a particular country should be based on some of the programmatic characteristics, vaccine supply, vaccine price, as well as the local and regional prevalence of vaccine serotypes and the antimicrobial resistance. So bottom line was, in epidemiological settings with substantial burden attributable to 19A and 6C, 6C has a similar cross-protectivity with the 6A, a vaccine containing 6 and 19 may have a additional benefit. Then what about the serotype 3? The third additional serotype which PCV13 had. The evidences from the various countries, especially the 7 countries, Denmark, France, Greece, Portugal, Sweden, UK and USA, showed a limited or no effectiveness of 13-valent pneumococcal conjugated vaccine against serotype 3 invasive pneumococcal disease and its carriage. This is because of some very peculiar characteristics of serotype 3, which of course we will not go in detail of it because of want of time. At the same time, we have a low prevalence of serotype 3 in India, and the prevalence is less than 1% as per the various studies which has been conducted in India. So as far as the serotype 3's ineffectiveness is concerned, there has been substantial evidence for lack of efficacy of serotype 3 component of PCVs. Evidences suggest PCV13 has a lesser effect in comparison with the other serotypes. The most recent US epidemiological data from 16 to 17 also showed no indirect effect on serotype 3 disease in adults. The UK epidemiological data up to mid-17 also indicated that the PCV13 use in infants has no direct or indirect effect on the PCV3 invasive disease and that carriage of serotype 3. Now what is the distribution and prevalence of various serotypes across globe? Now let us first look at the serotype 3 itself. In Asia, it is 1.4%, Africa 1.1%, Latin America and Caribbean countries 2.2%, while India it is just a mere 1%. So on top of the ineffectiveness, there is lesser prevalence of this particular strains especially in India. So what is WHO position and SAG recommendation about this serotype 3? It said that PCV10 of course does not have a serotype 3, so there is no question of protectiveness, but PCV13, there is little or inconsistent advantage. Now, 2 serotypes which were removed from the previously available 10-valent vaccine, what were they? They were 4 and 18C. What is their prevalence in various countries? As far as the serotype 4 is concerned, Asia prevalence is 1.6%, Africa 2.3%, Latin America 1.6%, India is almost 0%. 18C prevalence is concerned, Asia 2.4%, Africa 1.4%, Latin America 4.3%, again in India 1%. About the other parts of the world, about serotype 4, Chile 0%, Colombia 1.1, Brazil 0.00. So almost negligible or no prevalence of serotype 4. 18C, again minuscule in various countries ranging from 0 to 0.8. So as far as our India is concerned, various studies showed serotype 4 0% and serotype 18C 0.8 to 1%. Now what are the evidences of 6A and 19A? Direct protection versus the indirect protection. Now there has been shown that there are evidences of direct effect of serotypes 6 and 19A in IPD in one country using PCV10 previously available, suggests that there is some evidence of cross protection. However, as far as the functional antibodies, OPA titers and GMC is concerned, post-booster percentage of recipients, when we compared 6A and 6A and 19A, when we compared 10-valent and the 13th-valent vaccine, that 10-valent vaccine has a protective value of 16 to 67%, while 13-valent vaccine had a more than 99% protection. And what was the difference in the OPA GMT titers? The post-primary, in post-primary series, it was 15 to 77 times higher with PCV13. And in post-booster studies, it was 23 to 32 times higher in the PCV13 arm. So lower cross-reactive responses to 19A might explain that the reported failure of PCV10 to reduce 19A colonization in children and provide indirect protection against 19A in unvaccinated children. Even among the vaccinated age cohorts, PCV10 might provide inadequate protection, as suggested in the Belgium, which has an immediate increase in the number of pediatric patients with 19A invasive pneumococcal disease after a switch from 13 to 10. What was it? In the period of 2016-17, they switched from PCV13 to PCV10, and then there was a sudden increase in the number of cases. So that showed that PCV13 was better protective, has a better protective effect than the PCV10. Now as far as the 19A distribution is concerned in various Latin American countries, what was the status before the PCV10 which was used in those countries and after the use of PCV10? As you can see from the red boxes in the different areas for 19A, the first line is the pre-vaccinated vaccination era, second line is post-vaccination. So percentage increased from 4.8 to 29.7, year 5.2 to 29.2, 8.9 to 39. Almost every countries there was increase in percentage. That means that particular vaccine was not protective, was no cross-protective effect against that particular strains, and hence that number increased when the other number decreased. Similarly for the other countries. So WHO position and SEG recommendation on serotypes 6A and 19A. For 6A, the evidences indicate that PCV13 induces higher serotype 6A GMCs and OPA titers with higher percentage of responders. And for 19A, both induces an antibody response, but the PCV13 induces higher GMCs as well as higher responders. What is IAP's recommendation? Direct protection rendered by the serotype included in a vaccine formulation is definitely superior to any cross protection offered by the unrelated serotypes, even in the same group, in any PCV containing formulations. Now a word about the newly developed or newly arrived 10-valent vaccine. It contains serotypes 1, 5, 6A, 6B, 7F, 9V, 14, 19A, 19F and 23F. So 2 new serotypes minus 2 old serotypes. Again 10-valent vaccine, again a WHO qualified vaccine. And if we look at the various percentage of coverage in comparison with different vaccines, if we look at the PCV13 first, it has coverage of 72%, new PCV10 has coverage of 71%, and old PCV10 has a coverage of 63%. As far as the Indian studies are concerned, ACIP studies, another Indian studies, basis studies, 78%, 77% and 64%. And the 10-year review data also suggested same 76%, 73% and 67%. So if we look at the coverage of various prevalent serotype is concerned by these vaccines and we compare them, that was the result which we previously saw. But if we look at the worldwide coverage of newly 10-valent vaccine, in Asia, total coverage is 68%, Africa 72%, Latin America 74%, ACIP studies in India 71%, PDOP studies 73.6%. So overall globally it covers 71% of the prevalent strains, while in India it covers even more, 73%. Of course, this has not seen a day of light overnight. It has passed through the number of studies. We will not go into detail of the various studies, but the studies have compared them with the Pneumovax vaccine, that is 23-valent vaccine, 13-valent vaccine, and as well as the previously available 10-valent vaccine, with the end results of safety and immunogenicity, and it has passed through all this study data, and some of the studies are still ongoing, and even the post-marketing licensure studies is ongoing study right now. So we can conclude that all confirmatory primary and secondary objectives were made, and this newly 10-valent vaccine was highly immunogenic and induced a robust serotype-specific IgG and OPA responses for all 10 serotypes that were present in the vaccine, and the study data indicates a comparable immunogenicity of this vaccine with the previous 2 available vaccines using the WHO defined IgG endpoints as well as the OPA titers, and thus demonstrate a comparable efficacy. The robust OPA titer results are clinically significant in the light of increasing clinical importance assumed by OPA as well as IgG as an opso. Nasopharyngocytosis is considered as the primary mechanism of host defense against the pneumococcal disease. The importance of OPA is increasing evidence as it is being observed to correlate well with the protection offered by the IPDs. So this was well tolerated vaccine in routine schedule, and the WHO schedule 3+1 vaccine should be used below 2 years of age because of lack of studies beyond that. ACVIP recommendation, which has changed recently in 2021, this has also included this vaccine in it in 3+1 schedule with a booster administered between the age of 12 to 18 months. And this is even more important for India when India is planning to include this PCV vaccine in its immunization program. Some of the states have already included PCV in its immunization, and depending upon that experience, the other states will be shortly introducing this PCV vaccine in its armamentarium. So the cost will definitely be an important factor when India will require a huge number of doses for its EPI schedule. So friends, to summarize, we have PCV7 of course is now no longer available, PCV10 new and old, and the PCV13 with these different serotypes is available at present in our market, but this is not the end of the story. Still, coming up are the PCV14, PCV15 and PCV20. So let us wait for those days when we will see a PCV20 in our day-to-day practice. And what is the coverage by these different vaccines? This we have already seen. PCV13 covers 75%, old PCV10 covers 67%, while new PCV10 covers 74%. But what will be coverage when we have another vaccines with us? PCV14 when available, it will cover almost 78%. PCV15 again will cover 78%. And if we have a PCV20, it will cover almost 81% of the serotypes which are available, which are seen in the society. So let us wait, hope we see those PCV20 vaccine. Till that time, we should be practicing. Thank you. Thank you.
Before time, sir. Thank you so much. We have this pride and honor because sir is from Rajkot and is a chairperson at national level IAP ID chapter. Coming to the last session of the day, which is a panel discussion on intra-abdominal infection. And as panelists, we have Dr. Chetan Trivedi, sir. May I please request him to come up on the stage. Dr. Sameer Shah. Sir is a consultant pediatrician at Sameer Hospital and Narhari Hospital, Baroda. He is a secretary, Computer and Medical Informatics, Chapter IAP 2019-20, 21-22. Convener, Website Committee, Central IAP 2021. Executive Board member ID Chapter IAP 2021. National Coordinator, Association of Adolescent and Child Care in India. EB West Zone in Indian Child Abuse and Child Labor Chapter. Executive Board member, Academy of Pediatrics, Gujarat. Sports Secretary, IMA Baroda. Member of Editorial Committee, IMA Baroda since 2019. Welcome, sir. May I request Dr. Jayesh Sonwani, sir, to come up on stage. Sir is a practicing pediatrician and neonatologist at Satnam Hospital. He's an active IAP member, is a faculty member in various state conferences and workshops, active committee member in organizing district and state conferences, and has delivered many lectures and articles in various newspapers for public health awareness. Welcome, sir. And next, I would call upon Dr. Palak Hapani, who is an associate professor at PDU Medical College, Department of Pediatrics. Ma'am is also a joint secretary of Women's Wing, Rajkot. I welcome all the panelists, and now I welcome Dr. Raju Shah, sir, to moderate the session on intra-abdominal infections.
Hello, friends. Intra-abdominal infections are the very important part of pediatric practice, and many a times it is the type of infections that are difficult to manage because it requires a whole team. We need to have pediatrician, sometimes intensivist, radiologist, the microbiologist, as well as the pediatric surgeon. So it's a teamwork. So we all know that abdominal cavity is a Pandora's box, and many a times, even though we have suspected something, diagnosed something, and it can come out as something else. So it's always difficult. Few of the infections are common, few of the rare things are also there, and most of these infectious disease or pediatric forums, they are hardly discussed, and even if it is discussed, mainly the pediatric surgeons are mainly interacting rather than the pediatricians. So today, for the first time, we have pediatricians only going to interact in this session. Well, as this is an infectious disease on CME, we will be mainly talking of how do we manage medically rather than surgically. So we are not going to discuss about the surgical approaches and different alternatives of the surgical techniques. We will not discuss the systemic diseases which involve the abdominal organs or the infections, but intra-abdominal infections only. So with this epilogue, I'll now start the questions to the panelists. I am very thankful because they are excellent friends that they are going to react to this. So let's start with a case. A 8-year-old female complained of abdominal pain for a day, which was a colicky, periumbilical, severe, vomiting several times, mild fever, no urinary complaints, and not sparse stool for a day. On examination, temperature was 99.5, vitals normal. On examination per abdomen muscle guarding was there, and tenderness at McBurney's point. So very clear-cut diagnosis suggesting clinically of appendicitis. Lab test also were not accepting, showing that higher count and CRP little higher. Again, indirectly telling that it is a infection there. The USG again shown a non-compressible tubular tender structure, which confirm the diagnosis of appendicitis. Now, so this child was hospitalized and certain supportive treatment was given, and one sort of ceftriaxone was given to this side. So question is, many a times there is a issue of sonology, and many a times sonologists tell us different things on when they are telling, and the diagnosis of acute appendicitis, in many cases we are fully dependent on sonologists. So let's try to learn how sensitive this sonography for the diagnosis of acute appendicitis. What do we expect from diagnosis to look for the USG, and any special technique doing the sonography? Yeah, one of the panelists. Yes, Samir.
Sir, good afternoon to all. And sir has rightly said, sir has just opened the Pandora's box with the sonography, and we are lucky we will start with the sonography things. And it's what sir has said, it's a group that treat all the Pandora's box, and we having 4 panelists as a group. So I will try to summarize the things. What is sensitivity of the sonography? If we say the sonography, it will be totally depends on how the radiologist is experienced. Second important thing, what the machine they are used, and what is the exact position of the appendix and where it is present. All these 3 things, if we are keeping in mind all the studies what we just gone through, almost sensitivity is around 50 to 80%. Depends on this expertise. But specificity is very high in this sonography, and that's an important thing, how we see the appendix at which position, and the latest that compress what sir has already said, real-time sonography, it helps a lot with the clinical scoring system of the pediatric symptomology.
Give brief answers because we want to cover many things.
Yeah.
Okay, so that is there. So any comment?
Yeah.
Chetan?
So sensitivity of sonography in a diagnosis, I think in the tunes of 90%. Because now good machines are available and sonologists also been trained for that. Second thing is, when you see the appendix, what radiologists would like to see is what is the size, what is the thickness of the appendicular wall, what is the probe tenderness, then what is the compressibility, what is the structure which is surrounding appendix, whether it is a fat collection or a fluid collection, or these things we expect a radiologist to look for in ultrasound. And spatial technique, what they do is gradually compressing the cecum, and then they remove the ascending colon. They'll try to reach to the appendix, and that they will typically see the target lesion, and that's appendicitis. So if it is a non-compressible, if it is a tender, if it is a thickness more than 6 mm, and if the lumen is dilated, like the distended lumen, then it will give a diagnosis of appendicitis.
That's right. Most important part is whether, because nowadays with the sensitivity of the USG machines, they are so sensitive that they are telling, and majority of the times they are describing the whole structure in such a way that if you read it, if you will, that probably it is infective appendix.
Again,
but you have to read properly and try to differentiate whether it is really infective or not, because many a times they write that this is a structure of this length, there is some fluid inside, there is some fluid outside, there is a small filled either Ficolith or something like that. But these are all not actually acute appendicitis. So it's very important to differentiate, and a special technique as rightly prescribed will be very helpful in differentiating acute appendicitis from other things and from a normal appendix also.
Same thing, sir, with the contrast enhanced USG also give the more accurate diagnosis with the vascularity.
The management, surgical or medical, and how one can decide that management. Yes, Jay?
Good afternoon, everybody. By and large, the standard method of treatment for appendicitis would be surgical management. However, medical management can be initiated or it can be tried. Though, nevertheless, there have been incidences, there 20% chance of recurrence of appendicitis is there.
Now, in this case, which I described,
Yes,
what do you think should have been the management?
Yes, sir. As it is a short history, and the sonography, if it is telling us only an inflammatory condition or there is only appendicitis, there is no perforation, there is no gangrenous bowel, we can attempt for a medical method.
As far as early as possible, you try to remove it. So now it depends on the medical and surgical line of treatment. Yes, we can go for, because it is non-complicated, we can go for laparoscopic appendicectomy, and we can come out of within a day or two. Your patient will be, there is no length of stay in the hospital. Even antibiotics will not be required. So what we can do is, I think if the patient comes with uncomplicated appendicitis, first is we were to restrict the infections. So we'll start with the broad spectrum antibiotic first dose when it is there with us, because we decide that surgery, and if they decide, it will take a few hours. So it is not required that overnight you have to go for the surgery. You can wait for, say, few hours. If it has been done within 24-48 hours, I think there is no change in outcome. So yeah, definitely first we will try to go for antibiotic. We'll go for broad spectrum antibiotics.
What antibiotics and how long? Because
okay. So I think first, here I would like to can go for the Pepzo. That will cover. Even a ceftriaxone will be fair enough for this patient if it is uncomplicated appendicitis.
Anybody else want to add anything?
With aminoglycosides.
Whether you want to go for aminoglycoside or only one antibiotic should be quite okay.
Sir, anaerobic coverage should be given because bacterioids are more commonly associated.
So if you are using ceftriaxone, probably you might add metronidazole because you are going to cover the anaerobes. But if you are using piperacillin tazobactam, probably you don't need to add the metrozil or because it has the anaerobic covers also. So either of one. And as rightly pointed out, now the shift is coming to little more conservative. In the past, for appendicitis, only treatment was surgical removal. But now the things are changing, and in Europe and USA also, they are, because now there is another armamentarium, and they call it interval appendicectomy. What is that, and how do we decide about that?
So yes, as you said, there is one or more option, because people are thinking that there are some intra-abdominal infections where we can go for antibiotics and we can control the infection. Similarly, why can't we go for the antibiotics, proper broad spectrum antibiotics, and we can cover it up and we can control the infection. Now, when the situation is like this, there is subacute appendicitis, and we don't have to go rush for the surgical treatment. We can give the broad spectrum antibiotics, we can give the fluid supports, and within 2 or 3 days, we can just control the infection. And then we can shift it to oral and you can discharge. But the issue is, once you discharge, there are chances that 20% there can be relapse. So people are thinking, yes, we have to remove the appendix. So at 4 to 6 weeks of age, they will go for appendicectomy, and that is called interval appendicectomy. So you don't do it right at the first time. You just control the infection. Then once patient is settled, then 4 to 6 weeks later you can do. Or in between, if you get
whenever a child is presented to us, there are two ways. One is, child is not that bad. Child is looking quite okay, just like a subacute appendicitis. Then there is no need to rush at all, and it has been found that almost 80% of the children do not need surgery. They are all right with medical treatment only, and they are not even referred for surgery. But some of them, they develop relapse, or some of them are not quite okay. They might come back with a pain after about, say, 2 weeks, 3 weeks, or 4 weeks. Then properly planned surgery is planned, and that is what we call is interval appendicectomy. In some children, if there is no response after 5 days of management, then you can go for immediate surgical management. By that time, child is quite okay and medically properly managed. So there are, sometimes we are clinically thinking of appendicitis, but it may be little different. What are those surgical and non-surgical conditions? Yes, Jai?
So Meckel's diverticulum is the one, and interstitial lymphomas sometimes, and also renal, any malignancies. They have been occult malignancy and then they present with...
acute appendicitis is acute condition. It's,
yes,
so these are all chronic conditions what you are talking. Yes,
sir.
Amir, you want to add?
Meckel's diverticulum is the one.
Yes, Meckel's, yes.
With the age of group, we have to definitely consider functional abdominal pain. That is the important thing that we should not miss, because that is a different management is totally there. No, the medical management already, Meckel's diverticulum, all the congenital abnormality, sometimes intussusception may be there, that may be presented subacute intussusception like that way. Then the other chronic hepatitis or this cholecystitis may it present with such type of the pain. So
we would like to more concentrate because it's an inguinal area. So whatever some of the sessions that might come in the inguinal area. Yes.
There may be a torsion of undescended testis or any tubo-ovarial complications.
Yes. So ovarian, undescended testis, yes, torsion. Ovarian torsion or ovarian infection. Sometimes pelvic inflammatory disease also can, and typhlitis or infection, beginning of earlier enteric fever with typhlitis also can present like this. So some of these conditions can be ruled out if it is
adolescent girls, usually it is, adolescent appendicitis is also common, as well as the ovarian cyst. Because torsion ovarian cyst is very common and it is very close differential diagnosis. So you have to keep it very toxic child, adolescent girl. I think we keep a second option of that alternative.
Let's go to another case. A 7-year-old male presented with high-grade fever, severe pain in abdomen, temperature 102, heart rate 120. There was a tenderness in right hypochondrium and epigastric region. Liver was 6 centimeter. Severe tenderness that was present. Spleen not palpable. There was little diminished air entry on the right base. This was the lab reports. SGPT was little high. Blood sugar was normal. Creatinine was normal. Count was high. And this is what the sonography. The report says that it is a developing liver abscess. Okay. Well, diagnosis of liver abscess is not that difficult with the advent of sonography. Whenever you have a doubt, you go for it and you will find it. But it's not that uncommon conditions. In the past, we thought that it is not that commonly seen. But if you now ask any pediatrician, within last 1 year, they must have seen 1 or 2 cases. So it's not that common. But the issues with the liver abscess is the etiological diagnosis and how to manage those, because it's not going to be a short management. So how do we differentiate what is the more common, whether it is pyogenic or amoebic, and what are the settings in which we suspect either pyogenic or amoebic, and can we differentiate on basis of clinical picture? So these are the issues that we are going to discuss. So yes,
so pyogenic liver abscess are more common, followed by amoebic, and very rarely there may be a tuberculous, fungal or helminthic etiology for liver abscess, but mainly with pyogenic. And there are certain pointers because liver is getting blood supply from portal vein and hepatic artery. So any source of infection from this source can lead to infection in liver. So child with history of colitis, appendicitis or any septic thromboembolism are at risk for pyogenic liver abscess. The direct spread of infection can occur through biliary tract. So if child having history of recurrent gallstone or any anomalous in biliary tract, then also risk for pyogenic liver abscess. Any direct liver injury, penetrating liver trauma also predisposed to pyogenic. While amoebic liver abscess occurs as a complication of intestinal amoebiasis. So child with a risk factor of sickle cell or chronic granulomatous disease, immunodeficiency syndrome or malnutrition, they are risk for amoebic liver abscess.
Anybody wants to add anything?
With the history of the such type of the places visit in near past, that may be one of the good indicator for the amoebic liver abscess also.
So, certain clinical, things like, if the child is less than 5 years, very high chance of pyogenic only. If child constitutional symptoms are very aggressive or in a very short duration, again pyogenic. If it is a chronic disease, child's age is more than 5-7 years, there were other problem of pain in abdomen, recurrent abdominal pain or loose motion sometime, then we are more thinking of amoebic. So these are all different settings in which you can make the diagnosis or differentiate. The clinical picture also, as very rightly pointed out, some of those pictures are there that will tell you that it is more likely to be pyogenic. And if you look at the total data available, almost I would say that 90% of them they are more likely to be pyogenic, only 10% or less than 10%. And in the Western world, it is even less than 2% of amoebic, rest all are pyogenic. So with the even the child coming from higher socioeconomic class, again it is more of a pyogenic, less of amoebic. So that is how, different settings, different pictures will help you in differentiating or suspecting the type of abscesses. Now management is very important because our selection of antibiotics, because here we are going to give antibiotics for a long period. So what should be, and it will be based on the likely organisms. So what are the likely organisms and what empirical antibiotics you will start in pyogenic liver abscess?
So it depends on from where the infection is got. As she rightly said, it can be from biliary tract, it can be from the portal vein, it can be from contiguous spread, or it can be from external injury, or if nothing is found, and if it is a hematogenic spread, or nothing is found, it can be cryptogenic. So depending upon that, suppose we have GI infection which has been traveled to the lymph node, liver. So it will be more of anaerobic organisms. It will be more of a gram-negative organisms, maybe a E. coli, Klebsiella. It can be a staphylococcal also, because ultimately it can come from cryptogenic. It is more common. And anaerobes also, so Bacteria frigidis and Peptostreptococcus. So these three groups are very important. So either it is an anaerobes, gram-negative, or a staphylococcus. To cover these, I think we have to take help of the antibiotics. Now in this piperacillin tazobactam, that will be the good BL-BLI combination that will cover almost everything. Other than if we think very strongly it is staphylococcus, I think we have to cover with the vancomycin. Otherwise, piperacillin tazobactam will be fair enough. Or we can go for ceftriaxone with metrozil. So that will take care of the rest of the organism and the anaerobes. So ceftriaxone with metrozil or piperacillin tazobactam with or without vancomycin, we have to use. This is the standard line of treatment. Yes, if we are suspecting that is amoebic, or there is a chances of, suppose we have aspirated and we get nCoV sauce pus. In that case, I think if we suspect amoebic, we have to go for metrozil, that is oral, that will take care of the tropozoite in the liver. But we have to take care of the cyst in the colon. So after 10 days of metrozil, we have to go for dialoxanide, which is a gut sterilizer.
So now we all know that any infection which is below diaphragm, there is a very high chance of gram-negative infection. And though this situation is that some of these, if it is a hematogenic spread or it is a cryptogenic infection, then there is going to be a staph which is going to be a possibility. So in a setting where if there are multiple abscesses, probably there is a higher chance of that being staph infections. So multiple infections, higher chance of staph. If there is one infection to start with, and if there is something suggestive of that infection has come from intestine or some other area, then it is a more chance of certain type of ESBL producing infections, because nowadays this is the biggest issue. In a gram-negative, in the past it was easy to select the antibiotic, but in the recent past, because of the increased in the ESBL organisms especially, lots of, if you look at E. coli or Klebsiella, almost I would say that 70 to 80% of them, they are ESBL producing. So selection of antibiotic is going to be a very useful, and we have to be very careful in selecting the antibiotics. So in a pyogenic infection, I think staph cover is important, and then along with that, covering of these. Depending upon the situation, if the child is younger, probably you'll have to go for either of these two, piperacillin tazobactam plus vancomycin, or in some situations where you are not very sure that piperacillin tazobactam may cover everything, then probably meropenem and vancomycin can be also a good alternative, because that will cover anaerobes also as well as this. So this is how one can say. amoebic liver abscess is a last possibility, so don't start with probably matrogel only. You have to cover this, and then if there is no response, then only think of this. Now, along with that, the drainage is also equally important.
So duration
Yes,
is also important. We have to give the long duration
Yes.
antibiotic. That's a very important thing. Once we start, it should be at least 21 days. And for the amoebic abscess, at least we have to, what the already Chetan Bhai says, we have to go for the luminal antibiotics also. That we should not miss. Once we
Nowadays, with the availability of ultrasonography, ultrasonography guided percutaneous drainage is become a very, very common and simple way. And earlier you start doing it, it is better because it helps you in also making a clinical, etiological diagnosis. So earlier you can drain, it would be better. Sometimes surgeons are little say that you may not get anything, but probably if you get even something with the gram stain and other microbiological test, we can reach to a etiological diagnosis, and that helps in a long way, because how long to give antibiotics, which antibiotics to be continued, these all can be decided if you get the organism. So it helps you in getting the culture as well as the gram staining report. That helps you. And if you get the amoebic liver abscess, it becomes easier because then you can stop giving other antibiotics for a longer period. Normally you'll have to give for minimum 2 weeks, but in some cases you have to give as long as 4 weeks or so. So you have to be very careful and then decide. Otherwise, we have seen relapses, and we have seen that they need 2, 3 or 4 times drainage of the liver abscess. So liver abscess, though looks very diagnostically it is easy, but management is little difficult and tricky in those situations.
Yeah, so that's a problem, because when there is a partial liquefaction, the surgeons will not be very eager to do the aspiration, because what happens if they do the aspiration and then again there will be recollection, so there have to be twice they have to aspirate. So that's a problem. So the indication, yes, to differentiate between amoebic and pyogenic, it will help, but ultimately what they say is if it is more than say 1 to 2 like 10 centimeters, or if it is more than 100 cc, then you will aspirate, or it is imminent rupture. But practically so is a problem, because parents also, they have been very much apprehensive. So if you remove it once and again it is recollected, they will be having an issue. So these are really practical.
No, the issues are there, but you have to counsel the parents that probably the beginning you can tell that probably child might need twice because first for the diagnosis and second for further management, number one. Number two, in a Western world situation is worse, because nowadays the gram-negative resistance has increased to a greater level, and even there now they have the enterobacteriacin and enterocoli, which are even vancomycin resistant. So they have a bigger issues. Still, fortunately, we don't have reported vancomycin resistant type of this enterobacteriaceae or enterocoli, and so we are lucky that way. So at least vancomycin can help us in taking care of gram-positive organisms, staph plus enterococci and enterobacilli. So that's a very important thing.
Plus,
Yes.
sir, usually, practically, when we are seeing the second or third opinion always there, so it will be easy to convince the patient at that time of for the drainage. It's not a difficult.
No, if you have counseled them, it becomes little easier.
Yes.
So first sitting only you counsel, then probably, so then you are telling, but if you have counseled that no, we'll go for one drainage, then it becomes little difficult. So counseling in the first sitting itself is very, very important. That helps in a long run. Another case, 1.5-year-old male, fever 3 days, pain in abdomen, loose motions, history of recurrent abdominal pain for 6 months, family history of uncle had suffered from Cox before 5 years, had taken full AKT. On examination, non-sick looking, mild pallor, no cervical gland, all systems are normal. For all these type of cases, we normally go for sonography. That shows 3 to 5 mesenteric nodes, and the maximum size was 12 millimeter. The clinicians ordered for the Mentux test, which came as 10 millimeter, and child was started with 4 drugs AKT. So whether this is a correct diagnosis or something is wrong, and how do we interpret this, both USG as well as the Mentux test?
Sir, I would like to reconsider the diagnosis, because as per this scenario, we cannot consider as a positive contact history. And based on history and examination, child non-sick looking with normal systemic examination, I would rather go with non-specific mesenteric lymphadenitis rather than Cox abdomen.
So what are the points against? Why you will go against, not concur with the diagnosis?
Because the history exposure is long back, more than 5 years, and the patient contact is already treated.
And patient was not
And
born also that time.
child.
Yeah, so the history of contact is a very, very important. The history of contact for tuberculosis is last 2 years only, and that too if the contact is staying with the family, or at least has a frequent contact, and it's an open case. Otherwise, just a uncle treated before 5 years, full AKT, it's not a contact. Yes. So that's number one. Number two, even the report of USG. Yes, Chetan discussed about the lymphadenitis. This is a intra-abdominal lymphadenopathy and not lymphadenitis actually. So that's the difference. And in a Chetan, you want to tell?
Yeah. So ultimately, what happens whenever any patient with chronic abdominal pain, they will insist for the sonography, and for that matter, we have to go for. Yes, something we have to do it. If you don't do it, even parents they will get it done and will come with the report of this that 10 mm size of lymphadenopathy is there. You start some antibiotics because that will be very clear from there. So yes, what is the size that is important, and not only size. What is the structure? What is sonographically whether it is abnormal or not. And what is the situation of the structure surrounding this lymph node? See, if it is node which are been more than say 1.5 or even 2 centimeters, then it is significant. And what is the structure really? It has been necrotic or something like that. Then we have to consider. Otherwise, presence of lymph node doesn't make it that it is a lymphadenopathy. You have to treat with antibiotics. So that is very common issue.
So this is not tuberculous lymphadenopathy. But what about how do we manage this case?
Just I was going to say same thing, because it's definitely not related with the infection what the presentation is there. This may be a normal presentation of the any USD finding. If patient has not fever and then other part we had do to sonography, it comes positive. So we have to
So
not
friends,
treat
these are not patients of lymphadenitis, mesenteric lymphadenitis. It's a different picture. Don't treat with any antibiotics. This is a class of reactive lymphadenopathy, as we see in many, respiratory infections, some lymph nodes in cervical area. Similarly, you may find it, and in any child, even if a normal child, if you send for sonography, they will have 8-10 lymph nodes. They are 1 centimeter, 10 millimeter or 8 millimeter or 12 millimeter. They are of non-specific. There is no need to treat such thing. Just reassure parents, counsel them that this is not the disease that you need to treat, and his pain in abdomen is not because of that. So you might have to find out. Sometimes, functional abdominal pain is the commonest condition, recurrent functional abdominal pain. So you have to manage in a different way and not by any antibiotics or by AKT. So let's take one more case. 3.5-year-old female child presented with decreased urine output, distension of abdomen and edema, signs of free fluid ascites, past history of nephrotic syndrome, treated before 6 months. She was again put on steroid 2 milligram per day in 2 divided disease for about 15 days, but then she came back with fever, distension, pain in abdomen, temperature was there, distension was there, periumbilical skin red and shiny, and tenderness. So what is the likely diagnosis and management, likely organism and selection of antibiotics?
So here I think because we had a patient with known case of nephrotic syndrome 6 months back, and again it has come maybe with a relapse, and that's why it has been started with the steroids. So my first diagnosis, because any case of nephrotic syndrome, whenever there is something which is coming with a pain in abdomen or distension of abdomen, we know that it's a bacterial peritonitis, primary bacterial peritonitis, unless proved otherwise. And yes, we know that there are different types of peritonitis, primary bacterial peritonitis, secondary bacterial or tertiary. So primary is, usually secondary is when there is a rupture of hollow viscous and then there is infection which spreads in the peritoneum, it is secondary. But here it is a primary. Why? Because the case of nephrotic syndrome, we have ascites, we have loss of complements and immunoglobulins which has been lost because of nephrotic syndrome. Also, it is immunocompromised condition because they have already been given the steroids. So during this is a perfect site for the getting the infection, and that too in a peritoneum. Now when we talk about this situation, the encapsulated organisms, they come first. And in nephrotic syndrome and cirrhosis, these two are a condition where you get a primary bacterial peritonitis. Streptococcus pneumoniae is the organism. And primary, mind well, it is a mono organism. So usually we have to take care of streptococcus pneumoniae, and for that to cover, I think ceftriaxone is more than enough, and that which I would like to.
Streptococcus pneumoniae, okay, but this could be staph also because
Staph to
child
staph
is
and entro.
immunocompromised. If the child has received 2 milligram per kg of steroid for
Yeah.
15 days, this child is an immunocompromised child. So along with strep pneumonia, you have to keep in mind staph also.
Staph,
And
yeah.
when you start empirical antibiotic, you have to cover both and then manage, because this is going to be a very critical situation. And if a child, immunocompromised child, getting this type of infection, you have to manage properly. Otherwise, we might lose the child also. So, and then probably if there is a need, you have to take for diagnostic tap, get it examined, and try to get the culture also done, and try to reach to the etiological diagnosis, because that will help you a lot. So it's a very important, because these are the conditions which are though simple to diagnose but difficult to manage, because these are and will require antibiotics for a long period, and we need to continue steroids also. That's a very tricky situation in that situation to manage this patient. So I think as the time is less, we'll end with this. There is one more case of pancreatitis, but it's okay. Everything is mainly based on this. So to end the whole discussion, we all know that intra-abdominal infections is a vast subject. These common conditions we have discussed, but there are other important infections also, like primary or secondary bacterial peritonitis, other forms of peritonitis, pelvic inflammatory diseases, renal abscess, etc. is the other conditions. And though this seems to be a surgical subject, we pediatricians have a very vital role to play, because now medical management has become a more important management in this type of conditions, though it is a teamwork where we all have to work together and save these children. Thank you, friends. If any questions, it will be my pleasure to answer.
Thank you,
Thank you, panelists, for excellent interaction.
There are few questions in the chat box. If you can open it.
Yes.
Chat box.
There are 7 questions in chat. Yeah, cloxacillin is a good antibiotic for staph, especially the if it is a methicillin sensitive staph. Nowadays, Fluclox is available, or probably you'll have to use amoxiclave. Can be a good, as a
bargain
when it is not available. So that is how. Impetigo, what about the clindamycin? Clindamycin is required if it is there are large number, and if you are thinking of the step with toxins, then it is useful. Otherwise, not
Otherwise,
required.
cephalosporin is more than enough, I think, in Impetigo.
Blood culture is not available in all the places. What is the best investigations of at such places? If it is not available at your place, you can send the blood culture at other place also, because nowadays the courier services are easily available, and there are always network with the little better microbiologist centers, and I think you have to establish those networks and use it. There is no alternative to blood culture for many infectious conditions. Above 60 years, which PCV are advised? After 50
only
years,
one
again the PCV 13 is the only which has been, and as a conjugate, but we have to use also along with that. After nowadays in USA, they only advise PCV 13, but in our other countries and European countries, they also advise the polysaccharide vaccine. So PPV 13 should be also used after about 6 months of first giving PCV 13. How early age in child appendicitis common? Which antibiotic should save the life before investigations?
I think usually we get it in a 10 years and around. So 5 years and above we get the appendicitis, but it can occur earlier also. But when
it can occur up to 3 years, but normally after 4 or 5 years, because the tissues have developed in that way. So but it can happen.
So if it occurs earlier, then the more chances of perforation. Because the momentum is not been developed, so it will not control the infection. So that is important.
Antibiotics again will be more common in younger child, but the antibiotics again will be same that we are selected, that is the piperacillin tazobactam plus if there is a need for some other thing, but otherwise that should be.
I think the amoebic cause will be less in vertical.
appendicitis
So, no,
you
no, no.
don't get.
In liver abscess,
Yeah, liver
when you talk
abscess,
about
yes.
younger the children, less chances of amoebic infection.
Okay, so if there is any other question here from the floor, if no question, thank you very much, friends, for the excellent patient hearing also. Thank you.
I would like to thank all the panelists and Raju sir for moderating this session. I would request Dr. Kirti Patel to present a memento to Dr. Sameer Shah. I would request Dr. Bhallada sir to present a memento to Dr. Jayesh Sonwal. Dr. Jankana Sangvi, may I request ma'am to present a memento to Dr. Palak Hapani.
Good afternoon, everyone. Now I invite Dr. Trupti Vaishnavi, please present a memento to our very active, enthusiastic and very sincere secretary, Dr. Jhalak Shah. Thank you, Trupti. Over to Jhalak, please.
Before we end the session, on behalf of IAP Infectious Disease Chapter and Academy of Pediatrics Rajkot, we express our gratitude to all our faculty today from Rajkot and especially out of Rajkot for sparing a holiday for the academic session and traveling all the way to Rajkot. We are honored to have you all here today. I also thank on behalf of AOP Rajkot, I thank Dr. Yagnesh Popat, Chairperson of Infectious Disease Chapter, for providing us this opportunity to conduct the 7th ID Connect CME as a hybrid module. We are thankful to Central IAP for providing us this DIAP platform. Also, I thank all the delegates present here. And I also thank for the support from Serum Institute of India Private Limited, Panacea Biotech Limited, Curatio Healthcare, Lupin Respira Spiritus. On behalf of AOP Rajkot, on behalf of Dr. Jankana Sangvi, President, and myself, Dr. Jhalak Shah, Secretary of AOP Rajkot, I thank you all. Thank you so much for being here and making it a successful event.